The Committee on Health, Hospitals, and Human Services will come to order. I'd like to welcome everyone this day to the hearing, all of the distinguished panels. I would first like to begin by having a brief moment of silence for a legend in this legislature, the former Senator Alicia Chucky Hansen. Even though we had a moment of silence on St. Thomas yesterday, I think it's fitting, being that she represented the district of St. Croix for so many years. So I'd like everyone to stand and we'll have a moment of silence. Thank you very much. And my condolences to all the family and friends of our beloved Honorable Senator Alicia Chucky Hansen, and may the good Lord continue to bless her soul abundantly and she rest in peace. Amen. I would recognize any other senator if they wanted to offer condolences to the family. Senator Noville Francis.
Thank you very much, Mr. Chair. And again, I thank you for that moment of silence. And I wanted to, once again, as I did yesterday, express with great sadness and a very heavy heart and we got the news of the passing of former Senator Alicia Chucky Hansen. Push, push, push. I had the opportunity of working alongside Senator Hansen, and we go way back. We were looking at some photos when I got promoted to police sergeant back in 1991. You know, Senator Hansen was one of those senators that actually appeared at that promotion, and you know, so I've had the opportunity to see her at her best and at her worst, you know, over the years, and truly, I know that the family has really been hard hit. Most recently with a number of with deaths. And at this time, on the behalf of the 35th Legislature of the Virgin Islands, I'd just like to offer our sincere condolences to the family, loved ones, friends, and as well as all of the fans and supporters of Senator Hansen. This is a hard one, and you know, certainly, you know, we want her to rest in eternal peace. Thank you very much, Mr. Chair, for the time.
Thank you, Senator Francis. Senator Maurice James.
Thank you. Good morning, Virgin Islands, and thank you, Mr. Chair. Thanks again for allowing me another opportunity. I want to share an occasion where I saw former Senator Chucky Hansen in a different light, and that was in July 2022. I attended a veterans ball at DV, and on that occasion, two things she did struck me profoundly. One was there were no servers for the food, and she got in the line and started to serve the guests. During that same occasion, she had her husband's picture on the back of the booklet, and she spoke about how, you know, she was always in the front, but she couldn't do it without him and the support that he had given her all these years. And sometimes we see leaders and we forget that they're human beings with families and loved ones. And in that moment, I felt that Chucky, I'll say Chucky, and I'll say this, that it is said that at the end of life, we ask whether we loved well and if we were loved well. And it was obvious to me in that moment that she loved well and she was loved well. And so, again, I offer my condolences and to the family, the Hansen family, and the extended family, because as the president said, they've had a rough year. But God is with us, and may her memory be a blessing to her family, friends, and all of us in the Virgin Islands. Thank you, Mr. Chair.
Thank you, Senator Maurice C. James. Senator Vice Chair, Senator Gittins, you're recognized. Please turn on the mic media for Senator Gittins. Senator Gittins, we're not hearing you. Oh, Senator Blyden, I'm sorry. Senator Blyden, we're not hearing you.
Morning. Yeah, good morning to the people of the Virgin Islands. As I stated yesterday, condolences to her family and her entire home circle. She truly was a trailblazer, and she was the people's senator. She really looked out for her people, and she advocated for them in any and every way possible to make life better for them. And again, I pray that her soul rests in eternal peace. And I did enjoying working with her in the 32nd legislature. And she truly was a champion of the people. And thank you again, Mr. Chair, for the time.
Thank you, Senator Blyden. Senator Carrion.
Good morning to you, my colleagues and testifiers and the people of Virgin Islands. And of course, I also join the whole Virgin Islands in mourning the loss of our dear colleague, Senator Alicia Chucky Hansen. Growing up and hearing about Chucky, she was an icon. She was a fighter for the people. You might not always agree with her positions on certain issues and the way how she handled certain things, but you can't deny that she was a voice. And she was a voice to the voiceless. And she tackled issues that sometimes were controversial and others didn't want to maybe focus attention to. So I agree with my colleagues that we have lost someone who has been a figure for years in the political arena and in the community as an activist. So my condolences to her husband, to her children, Elizabeth, who I also went to school with, and her supporters, and everyone in the Virgin Islands.
Thank you very much, Senator Carrion. Senator Kenny Gittins, Vice Chair, you're recognized. Please recognize the mic for Senator Gittins.
Please recognize the mic. Thank you. Good morning to all. I too want to share my condolences to the family. The Virgin Islands have certainly lost a giant. It's so hard to imagine now that a vibrant individual who you would always hear the sound of her voice, that we won't be able to hear it anymore. I know I will certainly miss the phone calls, the text messages, etc. Because like other colleagues have said, whether or not you were on the same side of the fence or you shared the same position that she did, she was always someone that you can learn from in this institution. And she had some knowledge for sure. And she will greatly be missed. To the family, I just say, hold on to faith, hold on to good memories, and may she rest in peace. Thank you.
Thank you, Vice Chair Senator Gittins. Truly a great, great public service. May she rest in peace. At this time, since we're endowed by the President's the presence of Vitima Director Daryl Jackson, I'll ask him to provide a territorial update on the storm Felipe. Director Jackson.
Good morning, Committee Chairman, Senator Fonseca, and the community senators present. Tropical Storm Felipe been very active last night, whether you were in the eastern part of the Commonwealth of Puerto Rico, if you were on the islands of St. Croix, St. Thomas, Water Island, or even in the British Virgin Islands. We had a lot of rain. We had up to 4 inches of rain last night over an island of St. John. We had between 2 to 4 inches on the islands of St. Croix and St. Thomas. So Tropical Storm Felipe has actually physically passed us by the center yesterday, but because of how big Felipe is, a lot of these outer rain bands are what we're feeding last night, and we will continue to see the effects both today, being Wednesday, as well as to Thursday. Right now, the projections for the total rainfall accumulation is up to 8 inches on St. Croix, St. Thomas, St. John. There's a lot of rain, a lot of needed rain for us, which is very, very important. The good news is there's no strong winds overall with this Tropical Storm Felipe. However, there are gusts up to 30 miles per hour, which will accompany some of these rain bands that come through. The impact of the territory right now, and we did have a very good call this morning with the Cabinet as far as being out and about with the Department of Public Works, Commissioner Gabriel, Commissioner Martinez, from VI Police, as well as VI Fire, EMS with Director George, and as well as our administrators. We've been all out and about since about 4:30 this morning, making assessments to the territory, the conditions, even with Department of Education. The Commissioner, Dion Wells-Huntington, chose to close the schools today on St. Croix, St. Thomas, and St. John. Government offices are open. The biggest impact I've seen, Senator, and for the community has to do with the barges running between the islands of St. Thomas and St. John. Specifically, the big red barge, I will put that out for the community. It is running, but is on an adjusted schedule. For this morning, it did start early, about 6 o'clock. The last scheduled morning runs is going to be at 9:30 this morning from St. John and at 10:30 from St. Thomas. And then it's going to do a break, and this is because of the weather conditions. Then it will do its last run from St. John at 3:30 this afternoon, and the last run at 4:30 from St. Thomas. So that's the biggest impact. Right now, the airports are open, both Cyril E. King and Henry E. Rolson. There's no impact negatively on the schedules or the flight line at this point. I would caution the community, if you're out and about, there's a lot of flooded road conditions, so please use caution as you're driving through. It does not take much water in order to hydroplane and lose control of your cars on the road. So it's very important we stay focused on that and stay safe out and about. We'll continue to get updates from National Weather Service in Puerto Rico, but right now that's the update for territory today, sir.
Thank you very much, Director Josh. And I think maybe one good thing that come from that weather is that I believe the good Lord has assisted us to extinguish that Bovoni landfill fire. So in a way, it's blessings, and of course, all the farmers and everybody else, I think, would be happy in addition to the regular community. At this time, Mr. Clerk, can you please call the roll?
Senator Marvin A. Blyden. Senator Blyden present. Senator Diane T. Capehart. Senator Capehart absent. Senator Samuel Carrion. Senator Carrion present. Senator Ray Fonseca.
I'm here.
Senator Fonseca present. Senator Norville E. Francis Jr. Senator Francis Jr. present. Senator Donna A. Fred Gregory. Senator Gregory absent. Senator Kenneth L. Gittins. Senator Kenneth L.
Here.
Senator Kenneth L. Gittins present. Senator Murray C. James. Senator James present. Senator Milton E. Potter. Senator Potter present.
Please mark Diane Capehart present.
Mr. Chairman, 8 present, 1 absent.
Thank you very much. We have a quorum. Mr. Clerk, can you please read Block 1 into the agenda, into the record?
Committee on Health, Hospital, and Human Services, the Honorable Ray Fonseca. October 4, 2023, committee meeting. Please be advised that the Committee on Health, Hospital, and Human Services will be conducting a meeting on Wednesday, October 4, 2023 at 9 a.m. in the Fritz E. Lawetz Legislative Room on St. Croix. Block 1, Bill number 35.0119, an act amending Title 19 Virgin Islands Code by adding a Chapter 7A directing the Department of Health to develop and approve mobile integrated healthcare programs, sponsored by Senator Maurice C. James. Invited testifiers, Dr. Tess Richards, Interim Executive Director, St. Thomas Eastern Medical Center Corporation, Ms. Tina M. Comisión, Esquire, MPA, Chief Executive Officer, Snyder Regional Medical Center, Ms. Jacqueline Greenidge, EMT Training Officer, Department of Health, Mr. Darrell D. Jassin, Director, Virgin Islands Territorial Emergency Management Agency, the Honorable Justa E. Tita E. Tita Encarnacion, Commissioner, Department of Health, Mr. Douglas Cook, Chief Executive Officer, Wang F. Louis Medical Center, Ms. Masarie Sproul Webster, Chief Executive Officer, Frederickstead Healthcare, Inc., and Mr. Darrell A. George, Senior Director, Virgin Islands Fire Service. That concludes the reading of Block 1.
Thank you, Mr. Clerk. Are there any correspondence to be read into the record?
Yes, Mr. Chairman.
Please proceed.
Honorable Ray Fonseca, Chairman, Committee on Health, Hospital, and Human Services, Capitol Building, St. Thomas, Virgin Islands, 00804. Dem Chairman Fonseca, please accept this correspondence as a formal notice of my absence from today's Committee of the Health, Hospital, and Human Services hearing, which is scheduled to begin at 9 a.m. in the Fritz E. Lawetz Conference Room on St. Croix. Please have all circulated documents shared with my office. Thank you for your consideration on this matter. Regards, Senator Donna A. Fred Gregory, Member, Committee on Health, Hospital, and Human Services.
Please mark Senator Donna Fred Gregory as excused. Any further correspondence?
Yes, Mr. Chairman, there is correspondence for the bill for today.
Okay. I would also like to take this moment to wish our esteemed colleague, our Senator Donna Fred Gregory, a happy birthday. We wish you a successful and a healthy and prosperous new year, and may all your wishes come true. Happy birthday, Senator Donna Fred Gregory. You may continue with the correspondence, Mr. Clerk.
Dear Senate body, this is a testimony in support of the Mobile Integrated Healthcare MIH program. As a family physician, I, Jermaine Owen, I return home determined to perform home visits for incapacitated community members. I have been privy to variety situation of these patients, some of them heartbreaking. As our population age, it will require more services, and thus I implore all of us to stand in support of the MIH and all entities that have proven to provide assistance to those often isolated or who have less than round-the-clock care. When a health provider can go into a home to see an elderly patient, they can perform a multifaceted assessment which can address the social, environmental, and physical limitations. I have been a hospital-based physician as well, and these aspects cannot be assessed in a hospital nor in the office. When an entity like the MIH program offers is early intervention for a patient who may end up in the ER or hospital otherwise if care is not timely or alarm sounded too late, as when a patient's friend may call 911 for a wellness check when the patient has not been heard from in days. Picture this: an elderly patient with pressure ulcers or buttocks has children that all work in a day but does not have enough hours given by a caregiver to turn her or change her. How are those ulcers going to heal when there is not enough attendance to her needs? Before entities like MIH, my performing a home visit was in vain because I had a few places to which to refer patients for services. Please do not let this program evaporate away because we do not see our own personal need now, but are concerned about the needs of others and for the overall benefit of the community. Respectfully yours, Jermaine Owen, MD. That concludes the reading of our correspondence.
Thank you, Mr. Clerk. Colleagues, who speaks to Bill number 35-0119?
Good morning, Mr. Chair. I do.
You may proceed, Senator James.
Thank you. In 2019, I was tasked by the governor with leading the integration of fire and EMS. During my research, I learned about mobile integrated healthcare programs. I soon discovered from Mrs. Jacqueline Greenwich Payne that after the hurricanes in 2017, the Department of Health started a community paramedicine program, which is a subset of MIH. In December 2022, several testifiers appeared in front of the 34th legislature to seek funding for the DOH program. Up until then, the Department of Health used disaster recovery and COVID-19 federal funds to run the program, which has served more than 1,800 patients since its inception. Bill number 34-0298 appropriated $500,000 from the Emergency Services Fund to the DOH to fund and maintain the program. The governor approved the bill but struck sections 1 and 2 because, as stated in his transmittal letter dated January 28, 2023, the appropriation should go to VI FEMS and not DOH. However, the Virgin Islands Fire and Emergency Management System does not have an MIH program, but DOH does. I decided that one of my first bills would be to give the Department of Health the legal authority to develop or approve mobile integrated healthcare programs within the territory. The ultimate objective of this bill, number 35-0119, is to improve the overall health and safety of our population. In its simplest definition, MIH is the provision of healthcare using patient-centered mobile resources in the out-of-hospital environment. This will not only alleviate the strain on our emergency services, but also enable them to focus their attention on high acuity, life-threatening medical calls where rapid response, treatment, and transport are critical. By investing in strategies that reduce the demand for EMS resources in non-emergent cases, we can create a more sustainable and fiscally responsible healthcare system. MIH programs can be established by any entity, including the Department of Health. Therefore, the legislation allows DOH to have a program as well as any other entity that wants to have one. Community paramedicine came before MIH, but MIH is broader. They both focus on finding ways to bring quality health care to those who need it. However, mobile integrated health, MIH, is an umbrella term for a more general model of strategy or strategy of care. Furthermore, MIH programs give medically underserved communities access to a variety of important out-of-hospital services. And I know the testifiers are going to talk specifically about how, especially DOH, how they've treated patients under their community paramedicine program. The bottom line is that both MIH and CP help patients who need medical attention, but not necessarily a trip to the ED, and aim to provide quality and cost-effective care. I want to say to the Department of Health, once this legislation is passed, and I believe that my colleagues will see that it should be passed, that there is, I want to point out, the Commission on Accreditation of Medical Transport Systems has created national accreditation standards for MIH programs. I see Ms. Payne is shaking her head, so she knows. So you already have the standards available for implementing and promulgating and implementing the regulations. The bottom line is that, well, before I say that, I want to thank the Legal Counsel's office because I went back and forth with them fine-tuning this legislation. But I want to say to my colleagues that by passing this legislation to establish mobile integrated healthcare programs in the VA, we have the opportunity to reduce ER visits and ambulance transports, to provide an alternative path to appropriate care while still maintaining rapid response for those who truly need it, improve healthcare outcomes for our constituents, enhance the efficiency of our emergency response system. This is the thing, we must meet people where they are and help them to navigate the health system. Thank you, Mr. Chairman, for that time.
Yes, thank you, Senator Maurice C. James, and I'm definitely in favor of this bill. As a matter of fact, we recently, with the Bovoni landfill fire, these are the kinds of instances where this would come into play in our community. I apologize, I forgot to allow Senator Diane Capehart to give a few words about our former Senator Alicia Chucky Hansen. Senator Capehart, you may proceed.
Yes, blessed good morning to all. I'm one of those colleagues that sit in this 35th that had the opportunity to serve with Alicia Chucky Hansen. As a freshman senator, we had our ups and downs, but that was the politics in here. After that, I like to say we kiss and we make up, and we put the politics beside of us. And our last gathering that we enjoyed together was at the Sea Trade, where, you know, we talked about what other islands and countries were doing, what the VI need to be doing, because now I was in the 35th legislature, and recommendations that she was making to myself, I would always hold these moments close. And then while we were, my colleagues and I were away for another training the other day, we were having dinner, and everyone had a story. And we all didn't even know that she was experiencing, you know, problems with her health, but we all had good stories to share, and we laughed about it. So I sit here today to give my condolences to her friends, her family, to Elizabeth, to Daddy, as she used to say for her husband, her son. My condolences. This warrior will always be remembered. And I say in this legislature, we've had women warriors. We've had Ruby Rouse. We've had Lorraine Berry. We had Chucky Hansen, who has blazed her way through this legislature and made an impact in this community. May God bless her soul. Thank you, Mr. Chair.
Thank you, Senator Diane T. Capehart. Senator Milton Potter, you allow a few words.
Yes, good morning. Thank you very much, Mr. Chair. Good morning, colleagues. Special good morning to our invited testifiers who are here before us today. I too would absolutely like to express my condolences to the family and friends and loved ones of former Senator Alicia Chucky Hansen. For sure, she was a relentless advocate for the people of this community, particularly the most vulnerable and underserved persons in our community. She was their voice. She was a champion for fairness and justice. And she will be seriously missed in this community. So I want to just express my deepest sympathies to her family and loved ones. And I think she, based on the contributions that she's made in this community, she will live on just in the memories, just in the serious and substantive pieces of legislation that she was able to successfully pass in this body. So thank you very much for the opportunity to just offer a few remarks on behalf of on the passing of former Senator Alicia Chucky Hansen. May she rest in eternal peace. Thank you.
Thank you, Senator Milton Potter. At this time, I'll ask media. We have a professionally prepared video that discusses the importance and all of the nuances of the mobile integrated healthcare program. So, media, can you please play the video? Thank you.
A blessed good morning to the listening audience out there. For those of you who don't know me, I am Jacqueline Greenwich Payne, the administrator for the Department of Health Mobile Integrated Healthcare Community Paramedicine Program. And what it is a program that goes into the homes through referrals, whether it's from the hospital, a physician, or even a family member, human services, and we go out into the community. We do inspections for the safety of the homes. We do education and the disease processes. And we teach the family members how to take care of their family members. We help them with diet, medication reconciliation, and wound care, and whatever it needs. It's a total wraparound service. But today, the members who have experienced the service will tell you about the service. Our mission is saving a community one person at a time. Thank you.
I am really happy this afternoon to have this opportunity to talk about the mobile health program for the Department of Health, especially the paramedicine component. I'm going to use a little bit of notes so I won't forget, but my husband had a stroke, who's right next to me, Ambassador Simon Jones Hengster. And by the way, they just had a big independence celebration, the 40th independence celebration of the Federation of St. Kitts Nevis. And he was at one time ambassador to CARICOM. But in 2016, he had a stroke. And that completely changed our lives. I am 76 years of age. And many of you know me from in the community. I'll give you a little bit of background for those of you who don't. I was assistant commissioner under 4 different administrations. Initially, all for St. Croix. All of this is pertinent to why I'm saying this. You'll understand why. First for St. Croix, and then eventually I became the assistant commissioner, and listen to the words, very important, assistant commissioner for prevention, health promotion, and protection. Prevention, health promotion, and protection. In addition to that, we started the Virgin Islands. I founded the Virgin Islands Medical Institute. The purpose of that was to improve the healthcare of everyone, but especially the most fragile, seniors. And we did Care Force, which was a drive for about 10 years. The person behind the camera used to help us, Earl Morris, I'm going to mention his name, right? We'd have Care Force. All of this was voluntary, and everybody, National Guard was involved, retired nurses, everybody, the community came out to immunize individuals to understand the importance of having immunizations. And we did it for 10 years until the Department of Health took over. Now remember, in those days, the Department of Health was everything. It wasn't just community health. It was hospitals, it was health centers, everybody was part. It was kind of all in one. So it was really a big project. So as you can see, I was busy. And then in 2016, my husband had a stroke. that change our lives, right? Because we don't have the services in the Virgin Islands that can help take care of individuals who are fragile. We just don't. So I had to change my lifestyle, not have my practice, and concentrate on my husband. Of course, my children help. We have 2 wonderful children, and I have helpers. But the importance of this mobile healthcare program is so important because for those of you who don't have anybody, right, this program brings you not only those with chronic diseases, but it reduces the 911 calls, which means it affects public safety. It increases the ability for us to do those 3 things we talked about: prevention, making sure you don't get sicker; health promotion, helping you to promote your health. And I know many of the insurance companies are doing that now. And protection, protecting the health that you presently have. So this mobile program is very important. Well, how did I find out about it? I was in a medical society meeting, because I'm the executive secretary treasurer, volunteer, medical society, and Dr. Ty Hunt was mentioning the program. And I said, wow, this is wonderful. Because for me, at 76, to try and take my husband in a wheelchair, you could look at the wheelchair, it's almost 50 pounds. For me to lift that into the car, I mean, it's impossible. It really is. So this mobile health program was so important to me. And they came out and they gave us our COVID vaccines and so forth. Today, I don't have the COVID vaccine. I wish it was here to give, but I do have flu vaccine that I ordered, and we're going to have Ms. Greenwich help me with that. But I wanted to let you know that I have worked with her. And I want you to come into the frame so that everybody could see you. I have worked with her before when I was the medical director for the St. Croix Rescue and also medical director at Hovenza. You know, she's one of these individuals that not only knows the information, she teaches it. And they taught it all through the Caribbean. So when I heard she was involved in this program, I had no doubts it was going to be a world program. So I signed up, they came, they gave the shots. So today, here again, we're promoting health, we're preventing, and we're also giving an opportunity for individuals just like my husband to be able to receive services. So kudos to your program. I'm so happy you're here. She's gonna give us our flu shot so you can see how easy that is to do. And I wanna just say, I think I'm gonna just end there and say, enough said, right? Everybody needs to support this program because it's a program that really helps everyone, but especially the most fragile. So now, Jackie, we're gonna do it, and I always do it on the left hand.
And this is Mr. Riley. Mr. Riley is one of my volunteers for EMS police.
And you notice they have on their masks because COVID again is raising its ugly head. And that's one of the reasons we want to get the boosters. And we're so glad that President Biden has made it possible for seniors, in fact, everybody, to be able to get the booster. So if you have insurance, some of that. But for the elderly, I know that they said it's free of charge and they're giving COVID tests and so forth. So pay attention. This is very important. Wear your mask when you're out in crowded areas. Daddy, you want to say anything?
I'm Simon B. Jones Hendrickson, married to this lovely lady, Dr. Cole Christian. She said she's 76, I'm 78. And this year is our 47th wedding anniversary. 47 years we've been married. We have 2 lovely children. Well, they're not children anymore, they're grown up, but you know, 2 adults. And I'm really grateful for this opportunity to participate in this program and indicate to the rest of the Virgin Islands and indeed the wider Caribbean, because this program goes around the region, that they should get involved in something like this.
Coming out, and I hope all success and continuation of this program.
And I really and truly appreciate you guys.
Thank you, Ms. Jackie.
Hi, good morning, Senators. My name is Richie D. I'm one of the patients for MIH, one of the best kept secret in the U.S. Virgin Islands. I also want to let the people that don't know about this program that it's not just for elderly, but it's for our future in reference to all of us are going to get old at some time. And with this, I would like you all to know we're not going to be young forever like we used to say forever young. This is a program that everybody who has a grandma, a mom, know at some time we can't rush go to the emergency room or go to one of these physician that say that they will treat us. So I would like you all to please, please, senators, take into consideration, because like I said, we're going to get old at some time and need health care. And it's not all of us could go in our pockets or piggy banks or under the mattress to get $1 or $2 to help. And this has been a very informative program with Ms. Greenidge and her staff. By the time that they came to my house, I felt like Hulk after feeling like Bruce Banner, a weak, mild-mannered person, because the intellectual knowledge that they gave me enhanced my growth, my confidence in being such a wonderful, wonderful person after that. It also helps with your skills as not to be half empty, but half full. When they educate you on all these pharmaceutical and the way that diabetics, cardiovascular, especially me having 2 heart attacks, it enhanced me to push and say, I think I can, I think I can. And with all the information that is given, I would ask you, please, please push forward this bill, because like I said, in the future, it's the best kept secret, and a lot of people know who have elderly people that we need these kinds of programs, because it's beneficial for us here who cannot go abroad, who don't have the resources to spread your wings. Since I had my 2 heart attacks, they came weekly to check on me. They showed me the way of how to take my medicine, what they were prescribed for, what does this one intakes, what the other one, and what I should and should not do. They even referred me to a log book. I even got to introduce you to my new friend, because when Jackie used to come by weekly every day, she would have this monitor here to check my heart rate and how my heart was doing. So this is my new good found friend, you know? And I would like you senators to please, please push forward to continue the grant and the funding for this. Because like I said, we're not getting any younger, okay? And like I said, all of this is worthy to the young and the old, because one day we'll meet from 16 to 60, hopefully 95. A lot of people are dying in the community, especially with cardiovascular. So this is very educational, and I would like you all support. And this has come genuinely from the heart. Thank you.
Good morning, Senators. My name is Rosemary Jarvis Simon. I'm an EMT, and I'm here to give you some information on the MIH program that helped me through my issues of being bitten by a brown recluse spider. I was bitten and was unaware of what I was bitten by, and as time went by, I realized that the area where I was bitten started to develop tenderness, pain, swollen, and it continued to get worse. By the time I realized that I should see or seek help, it was too late. My skin started to eat from inside out, and the area started to break down, the tissue started to break down and everything. I went to the hospital, and they told me there nothing that they could really do because it has already gotten out of control. Right there and then, I contact one Miss Jacqueline Greenidge Payne, who works for EMS at the time, and she told me there is an agency that comes around and deals with wound care, which was this program by name of MIH. MIH started to come to my home, and they visited me every other day until that wound healed, closed up, and now I'm back to norm. The reason why I'm telling you about this story is because I realized that MIH is for people like myself and like you or your family members that needs help and can't get the help that they need because of situations. And with them coming along, I realized that they provided more help than I really needed, and they stayed with me right out to the end till everything was healed. And I would continue to ask y'all senators, please provide and give MIH a chance, not just a chance, give them the opportunity to show what they could do out there for the community. And that would be for all 4 islands. Senators, remember, I'm also an EMT and I needed help. Also remember, you might need help too.
What a wonderful video. It just shows how important this mobile integrated healthcare programs are in the community. Okay, so at this time we're gonna now go to our testifiers. I'd like to start with a mic check. Commissioner en Comisión, can you just give your name and position, and then we'll go to St. Thomas.
Good morning, everyone. Justa y Encarnación, Commissioner of Health.
Yes, go ahead, from my right to left, and then we'll do Darrell at last.
I am Jacqueline Greenwich Payne, and I serve as the Acting Director for the Office of EMS Regulatory.
Good morning. I'm Ms. Sierra Sprout Webster. I'm the Chief Executive Officer of Federated Healthcare.
Senator, Director Darrell Joshton, Director for the Virgin Islands Territorial Emergency
And St. Thomas, if we start from Dr. Tess and then go to the other side.
Good morning, Dr. Tess Richards, Interim Executive Director at St. Thomas East End Medical Center Corporation.
A pleasant good morning, Tina Comisión, Chief Executive Officer of Schneider Regional Medical Center.
Good morning, Dr. Nicole Sims, Assistant Commissioner, Department of Health.
Good morning, Hadia Charles, Deputy Commissioner of Regulatory.
Good morning, Lyle Levin, Assistant Director of EMS for VI Fire and Emergency Medical Services. I'm here on behalf of Director Darrell George.
Thank you, and a special welcome to all the testifiers. We'll begin with the Honorable Commissioner Justa Encarnación, the Commissioner of the Department of Health. Commissioner, you may proceed with your testimony.
Thank you very much, and good day to everyone. Honorable Senator Ray Fonseca, Chair of the Committee on Health, Hospital, and Human Services, Senator Kenneth L. Gittens, Vice Chair, Senate President Novalee Francis, committee members, and all other committee members, non-committee members, and the viewing and listening audience near and far. I am Justa or Tita Encarnación, your Department of Health Commissioner for the Virgin Islands of the United States. I have with me today Dr. Nicole Cragwell Sims, Assistant Commissioner, Hadia Charles, Deputy Commissioner over the Regulatory Division, both appearing from St. Thomas, and Jacqueline Greenwich Payne, Acting Director, State EMS Regulatory Office, by my side. Thank you for the opportunity to provide testimony on Bill number 35-019, an act amendment entitled 19 of the Virgin Islands Code by adding Chapter 7A, directing the Department of Health to develop and approve mobile integrated healthcare programs sponsored by Senator Maurice C. James Esquire. The rising demand of emergency medical services due to an aging population and a declining workforce in the emergency medical services sector has created a significant challenge for many communities in fulfilling the healthcare needs of our most vulnerable population, especially the elderly. The Mobile Integrated Healthcare Program Community Paramedicine Component, MIHCP, was developed to identify chronically ill community members upon their hospital discharge and intervene effectively. The primary aim is to mitigate the necessity for the subsequent 911 interventions and reduce the burden on local hospital networks. This program represents an innovative approach to pre-hospital care. A part of the program is specifically trained paramedics and nurses respond to patients referred to by third parties and deliver treatment within their homes. Treatment plans align with the patient's plan of care, which may address a range of chronic conditions including diabetes, chronic obstructive pulmonary lung disease, congestive heart failure, and the care of comorbidities developed from those conditions, for example, pressure ulcers, among others. The 2017 Atlantic hurricane season stands as one of the most severe in our history, causing catastrophic damage to the territory. During this period, the medical team from the Department of Health's EMS, in collaboration with our Emergency Management Assistance Compact, or EMAC, partner, PAFFORD, was deployed to accompany the Red Cross on their mission to distribute cleaning supplies throughout the island of St. Croix. During this mission, a distressing situation emerged, with numerous elderly patients found without caregivers or abandoned by their families. This sad reality inspired the creation of the program in the Virgin Islands, drawing inspiration from their successful implementation of MIHCP in rural mainland communities. We recognize the potential benefits this program could bring to our community. Pafford Medical, a partner in the 2017 St. Croix EMAC agreement, expressed their willingness to support us further. In response, the VIDOH EMS division presented this program, and Pafford Medical mobilized 5 teams comprising certified wound care nurses, nurse practitioners, and a medical doctor. Together, we ventured into houses, communities, offering essential healthcare services. Additionally, nurses from the Department of Health, Primary Care, and Mental Health divisions joined us in delivering care to those in need. Dr. Gregory Moorman from Moorman Aesthetic Center generously offered his expertise, provided free wound debridement and consultations on wound care. The remarkable support extended beyond our immediate team, community and church organization, including Reverend Gary Moore, his wife, and members of the St. Croix Christian Church, as well as Carol Jeffers, a former paramedic with the Department of Health, rallied over first responders and church communities on the mainland. Their collective efforts exemplify the spirit of unity and compassion, contributing significantly to the recovery of our islands. Mobile Integrated Healthcare Community Paramedicine started as a pilot project in St. Croix with the intent to expand services to the St. Thomas St. John district. However, due to the funding challenges and the inability to hire the required staff to fulfill the mandates, we were unable to fully implement this program. In its inception, the program was operated through funding from the EMS budget, FEMA assistance with durable goods, and other support from Pafford and the private sector. With the support of the dedicated staff and limited funding, we continue to serve a number of patients in the St. Croix district and have been successful in reducing repeated hospitalization, ER visit, and most importantly, 911 calls while improving the quality of life for our residents. We have utilized the help of nurses from other programs to make some of these visits. However, this is not sustainable without dedicated personnel and a funding source. To be successful, employees and supplies are needed to do the work. Attached is also a copy of the budget with the final cost showing $1,253,985.50. The table of organization proposed is also attached. Based on the 2020 census, the U.S. Virgin Islands population was 87,146, of which 21.3% represent residents over the age of 65, while 19.6% represents residents 17 years and below. Further, approximately 29% of the U.S. Virgin Islands is uninsured or underinsured, and approximately 22% is below the federal poverty line. Repeated hospital and emergency room visits for indigent care are economic and social problems that plague our government. To date, we have enrolled 1,892 patients in the program. Currently, we see and care for 89 patients weekly, of which 6 are court-appointed through the Superior Court and the Department of Human Services Adult Protective Services. We have 16 pending referrals, with Pafford Medical providing staff and their uncertain future as a provider for healthcare provision and staffing. The Virgin Islands would be left without this needed service on St. Croix and would not be able to expand services to St. Thomas, St. John district. I would like to thank the Department of Health team and other public and private stakeholders who have supported this program over the years. Special thanks to the current members of the MIHCP. On behalf of the Department of Health, I want to thank you and the rest of the Committee on Health, Hospital, and Human Services for revisiting this legislation, and we look forward to your favorable support. Before I finish, I also want to, on behalf of the Department of Health and myself, express my condolences to the former Senator Chucky Hansen and her family. We are ready now to respond to any questions. And again, thank you for giving us the opportunity to address the Committee on Health, Hospital, and Human Services on this important legislation. Thank you.
Thank you, Commissioner of Health, Justa Encarnacion. Ms. Greenidge?
Good morning, Ms. Jacqueline Greenidge Payne. My testimony was the video of the patients bringing the services that we provide in the community. The MIH program is a very, very important program. Many states that has done it have developed it in different ways. And we're just happy that we're able to do it for the people in the territory and to be able to continue our services. Thank you.
Thank you very much, Ms. Greenidge Payne. Ms. Sproul-Webster?
Good morning, Honorable Senator Ray Fonseca, Chair of the Committee on Health, Hospitals, and Human Services, other committee members, all other senators, and our listening and viewing audience. I am Ms. Sierra Sproul-Webster, the Chief Executive Officer of Frederick Said Healthcare, which is otherwise known as FHC.
Can you speak a little closer to the mic? Yes.
As this is my first opportunity to testify to the Committee of Health, Hospitals, and Human Services during the 35th legislature of the Virgin Islands, please allow me to give a brief overview of FHC as it does relate to Bill number 35-0119. FHC is the only federally qualified health center operating on St. Croix. FQHCs provide high-quality healthcare services without the regard for the inability to pay. We have a robust sliding fee discount program, and no patient is ever denied services due to the inability to pay. In 2022, we provided care to over 10,000 unduplicated patients. This year, we are on track to exceed the patient count of 2022. We provide medical, dental, and behavioral health services at our 4 health center locations. We are a community-based and patient-directed organization. Our organization is governed by a board of directors, which includes a majority of members who receive their health care services from the health center. This ensures we are responsive to the needs of our patients and our community. We thank you for the opportunity to comment on Bill number 35-0119 regarding the development of the mobile integrated healthcare programs. It is our understanding that the primary driver for this legislation is the reduction in the use of the hospital emergency department for non-urgent care and to formalize mobile health services into legislation. In January 2022, the U.S. Census Bureau published an article regarding preventable visits to the emergency department with the headline, quote, "Most vulnerable or more likely to depend on emergency rooms for preventable care," end quote. The factors which are linked with emergency department utilization include income, education attainment, unemployment, lack of health insurance, and lack of access to a vehicle or internet services. This demographic describes the majority of Frederick Said Healthcare's patients. 99% of our patients have income below 200% of the poverty guidelines. 14% of our patients are uninsured for medical services, and 34% are uninsured for dental services. Our model of care is to provide timely, high-quality primary care services to prevent ambulatory care-sensitive hospitalizations. Those hospitalizations which can be prevented through primary care interventions. We have expanded our footprint on St. Croix to include 4 locations to remove the transportation barrier to care. We offer same-day appointments and walk-in care at all our locations to accommodate our patients. We provide access to medical professionals during the hours when our health center is closed, so patients have a resource other than 911 and/or the emergency department. Our services include the management of chronic diseases, treatment of acute conditions, and perhaps most importantly, preventative care services. We believe that our biggest contributions to the reduction in the use of the emergency department in St. Croix is the continued expansion of our services so that all of the most vulnerable, described by the U.S. Census Bureau, have access to primary care in the ambulatory setting. It is important for the committee to understand that Frederick State Healthcare does not limit its services to the four walls of our health centers. We have introduced telehealth services in 2015 to provide access to behavioral health services. With the onset of COVID-19 public health emergency, we expanded our telehealth services to medical. With the end of the pandemic, we continue to provide both behavioral health and medical services via telehealth. We also have extensive outreach programs to reach the underserved and engage them in care. These programs often use one of our 2 mobile units, which are typically staffed with outreach staff and/or nursing staff. This outreach includes health screenings, including HIV and other types of testing, risk reduction activities, including syringe exchange, and vaccines, including COVID-19 and the seasonal flu shots. Our outreach activities are a familiar sight at community events, such as the agricultural fair and other health screening activities. Our plan is to expand the use of our newest mobile unit for school-based services. This unit includes an exam table which converts for use as either a medical exam table or a dental exam chair. And we hope to bring both of these services to the school in the near future. I will now address Bill number 35119, and I'd like to share that in writing this testimony, I was not aware that MIH services were already existing. It speaks to one of the testifiers, Mr. Ritchie's point about this being a well-kept secret. No, I know of Pafford, and honestly, we do work with Pafford Health, but it was never explained or never understood that it's the MIH program and that it actually is a program of Department of Health. So it does speak to, though we're a small community, the communication isn't the best at times. So it's worded, and I'll read it as I have it, but I just wanted to apologize and explain that I wasn't aware, and it's more written in terms of developing the program. The bill pending before the legislature provides a framework for the development of a mobile integrated healthcare program to reduce reliance on the emergency department for non-urgent care. Through our research, it is our understanding that such a program would use community paramedics to provide care in the patient's home at the direction of the patient's treating physician. This type of care might include conducting blood glucose checks, drawing blood for lab testing, starting IVs, and administering medications. These community paramedics would be required to have additional training over and above that of a paramedic and would only provide these services at the direction of the treating physician. As an example for how this would work, a treating physician would place an order with the community paramedic to perform a service such as drawing blood for the lab testing, and the community paramedic would travel to the patient's home to complete the service. Perhaps the patient is elderly or does not have access to transportation, and the treating physician does not need to conduct a physical examination of the patient, but needs the lab work to determine the best course of treatment for the patient. We support the development of a community paramedic program in the Virgin Islands, and we would utilize their services to augment our in-person and telehealth visits. We urge the legislature to consider the additional workload this would place on emergency medical service systems and ensure the reliability of these services through adequate paramedic staffing levels. In order for this system to work, the community paramedic must have time with their daily schedule to perform the service. The model is based on the community paramedic having time between emergency runs to engage in these activities. This, unfortunately, is not always the case, and therein lies the problem with the model. Should a treating physician place an order for a service on a day when emergencies consume the community paramedics, that service will not be completed. This may or may not have significant health consequences depending on the nature of the service ordered, but it will leave the treating physician uncomfortable using a system which has built-in levels of unreliability. We have some concerns with the emergency department avoidance component of the program. Our understanding is that this program would have an EMS provider who responds to a 911 call, consult with online medical personnel to seek medical direction, and perhaps use the community paramedic to manage the patient rather than to transfer the emergency department. Our concern is the consultation with medical personnel for medical direction and the lack of a clarity around who these medical personnel would be. Unless EMS personnel have access to medical personnel 24/7, the program would be limited in its effectiveness. Although FHC provides access to care for our patients after clinic hours, it is through a call center and it is not an appropriate venue for emergency situations. Calls are answered by a call center who relays the information to the provider. The provider then calls the patients. Reaching one of our providers through the system can take up to 30 minutes, which is not timely for an emergency situation. FHC's system of care cannot support the use of our medical providers as the online medical personnel with whom the emergency medical service community paramedic could consult. We believe for this system to be effective, emergency department personnel would be the best resource for online consultations with the community paramedics, as the emergency departments are staffed 24/7 with personnel who are experts in emergency medicine. We urge the legislature to consider this workload. This workload would place on the emergency department systems and ensure the reliability of these services throughout adequate staffing. We also would like to take the opportunity to encourage the training of locals within our community, as we presently are spending quite a bit of money on these outside contracts with Parford, for example. EMS training could be done with our young people in less than 2 months. But anyway, we would like to make that recommendation, and we thank you for the opportunity to present this testimony, and thank you for your ongoing support of Frederiksted Healthcare and the healthcare systems of the Virgin Islands. Respectfully, Ms. Iris Brown-Webster.
Thank you very much. We'll now go to St. Thomas. Dr. Tess Richards, you may proceed with your testimony.
Good morning. Committee on Health, Hospitals, and Human Services Chairman, Honorable Senator Ray Fonseca, members of the 35th Legislature's Committee on Health, Hospitals, and Human Services, other members of the 35th Legislature of the U.S. Virgin Islands, and the viewing and listening public. I am Dr. Tess Richards, the Interim Executive Director at St. Thomas East End Medical Center Corporation, hereafter referred to as STEAM-CC. Before I begin, I would also like to offer my condolences to the family of Senator Alicia Hansen, and to offer prayers of comfort and healing during this really difficult time for her family and her friends and her loved ones. St. Thomas East End Medical Center Corporation is pleased to give testimony this morning in full support of Bill number 35-0119, which proposes to amend Title 19 of the Virgin Islands Code by adding a chapter to develop a mobile integrated health program, or MIH program. With the appropriate staffing and processes in place, an MIH program will provide a number of benefits for our community. 1, prevention of unnecessary emergency department visits. With our limited resources and only one hospital on the island, it is imperative that the Schneider Regional Medical Center Emergency Department be utilized for emergencies only. However, as is the case nationwide, our emergency department is often inappropriately utilized. SRMC Emergency Department is used as a medical home for some patients for several reasons. A, some patients are not sure if they're having a true emergency, so they seek care at the emergency department. B, some patients do not have a primary care provider. So in their eyes, their only option is to seek care at the hospital. Both of the aforementioned issues can be addressed with an MIH program in place. The trained MIH staff can assess patients and determine whether or not an emergency department visit is warranted. And with the proper support, the MIH team can facilitate provider and patient connection to coordinate the needs of the patients so that patients who do not have primary care providers can easily be linked to care and actually have appointments scheduled in real time. So that's number one. Number two, decreased rate of readmission to the hospital. Hospital readmissions are costly and can pose a risk to the patient. Having a member of the MIH team reach out to a recently discharged patient is beneficial in a number of ways. The MIH staff can review the discharge instructions with the patient and provide clarity regarding the instructions. The MIH staff can make sure the patient has all of the recommended medications and is actually taking those medications the way they were prescribed. When necessary, the team members can actually assist the patient by filling the pill box every week to ensure the patient is taking those medications. MIH staff can make sure the patient has appropriate follow-up by making appointments as recommended by the discharge team, and the team members can perform a needs assessment to address the whole patient. Evaluating the patient's social needs and evaluating the patient's home itself can result in decreased infection and fall rates. Addressing the whole patient, which is huge, will really help to bridge any gaps in patient care and safety for our vulnerable population. 3 is cost avoidance. MIH programs are designed with prevention in mind. In other words, by decreasing the number of ED visits and hospital readmissions, the program serves to avoid costs, resulting in a decrease in our healthcare system's financial burden. 4 is just other. You know, the concept of meeting patients where they are in their homes creates a sense of more personalized care for the patient. This will likely result in increased patient compliance with medical recommendations. MIH programs can increase the frequency of medical contacts, paramedics, physician's assistants, nurses. And we know increased contact with patients increases patient satisfaction and patient compliance. Patients with limited mobility and limited transportation will have increased access to care because the MIH staff will be directly in their homes. MIH teams can also incorporate teach-back methods into their processes to truly gauge patient understanding. This will enable and empower our patients by teaching them self-management techniques. For example, the diabetic can learn how to properly manage high and low blood glucose levels, and more importantly, how to avoid them altogether. Decreasing barriers, that's the final one. Frequent encounters with the MIH team will result in relationships built on trust and respect. And this will likely allay fears about seeking medical care that some patients currently have, including our undocumented patients. As an FQHC, STEAM-CC's main goal is to ensure that everyone receives the healthcare they need and deserve. An MIH program can help us accomplish this through increased contact with patients, so increased access, and by linking patients with primary care providers, so increased entry into care. A fully functioning, appropriately staffed mobile integrated health program will serve to bridge the gap in access to care and will provide clinical, social, and financial benefits to our community and healthcare system. St. Thomas East End Medical Center Corporation stands in full support of this bill. Thank you for allowing me to present testimony this morning and for making the health and welfare of our community a priority. I'll answer any questions anyone has at this point.
Thank you, Dr. Tess Richards. We're going to go to Tina. Before we get to you, we're going to go to VITEMA Director Darrell Joshins. You may proceed.
Good morning, Senator Ray Fonseca, Chairman, the Committee on Health, Hospitals, and Human Services, other committee members, the 35th legislative staff, and those in the viewing and listening audience. I am Darrell D. Joshin, the Director of the Virgin Islands Territorial Emergency Management Agency, VITEMA, and I'm here today to provide testimony in support of Bill number 35-0119, an act amending Title 19, the Virgin Islands Code, by adding a Chapter 7A, directing the Department of Health to develop and approve mobile integrated healthcare programs sponsored by Senator Maurice C. James. For background, VITEMA is responsible for the Territorial 911 Emergency Communications Center, known as the ECC, which provides the ability for individuals to call from a landline or mobile phone to 911 for emergencies which require immediate assessment and potential dispatch of first responders by fire, emergency medical services, or police. In some cases, as in an overturned vehicle, the immediate dispatch of all three first responders occur. Currently, the requests for emergency services are received by voice, phone call, and dispatch also by voice by radio on the Bureau of Information Technology, BIT, maintained trunking system. The VITEMA 911 ECC are distinct by each district, with 911 St. Croix serving the island of St. Croix, and the 911 ECC St. Thomas serving the islands of St. Thomas, St. John, and Water Island. Incoming calls can be transferred between 911 ECCs, but dispatching of fire, EMS, or police is limited to within each district distinct. There are some areas of the territory where, due to limited cell phone coverage, there is no 911 coverage, and in some cases, and by design of the mobile network carriers, calls for 911 go to the strongest carrier, which in some cases is the BVI 911 ECC or the Puerto Rico 911 ECC. Those calls are manually transferred by operators in the BVI or Puerto Rico to the appropriate territorial 911 ECC on St. Thomas or St. Croix. Finally, members of the 911 ECC who are dispatchers are part of the United Steelworkers Collective Bargaining Unit. Proposed changes under this bill. There are three sections in Bill number 35-0119 which refer to 911. First is the section 156, subsection B, which refers to, quote, 911 nurse triage lines, end quote. The second is also in section 156, subsection Echo 9, referring to having, quote, an activated 911 system, end quote. And the third is in subsection F for Foxtrot, which refers to, quote, 911 triage assessment tools, end quote. The current VITEMA 911 ECC does not have any 911 nurse triage phone lines, nor is there a requirement for qualified nurses to be part of the 911 ECC. 911 operators do use a Q card system called a Pro QA to assist in any medical calls for emergency and permits the operator and caller to conduct a very basic assessment on the level of the emergency. The VITEMA 911 is currently active in 99% voice response capability, but does have a small number of calls received automatically from businesses which have security active alarms, which result in 911 ECC operator dispatching VI police. In the past, discussions with VITEMA and the private sector medical response companies with services which provide calls for assistance, such as an alert from a fall, requires the individual to activate a responder which goes directly to a service company and does not go to 911. The recent upgrade in the VITEMA telecommunications system, such additional capability may now be available, but it will take joint testing to validate and determine any limitations, such as geographic non-available areas, on a case-by-case basis. In closing, as with any new technology and variety of telecommunications providers, extensive testing and trialing are required before deploying a system for medical health professionals and patients. VITEMA is willing to work with the Department of Health and any vendors in providing a working solution to a mobile integrated healthcare programs. Again, VITEMA supports Bill number 35-0119, which seeks to amend Title 19 Virgin Islands Code by adding Chapter 7A, directing the Department of Health to develop and approve mobile integrated healthcare program. Thank you, Committee Chairman Senator Ray Fonseca, for opportunity to provide testimony. I'm prepared to address any questions you may have at this time.
Thank you, Director Daryl Joshin of VITEMA. Next, we'll go to Tina Ng Comisión, Chief Executive Officer, Snyder Regional Medical Center. You may proceed, Tina.
Good morning, Honorable Senator Ray Fonseca, Chairman of the Committee on Health, Hospitals, and Human Services, other senators present, and to the listening and viewing audience. I'm attorney Tina M. Comisiong, Chief Executive Officer of Schneider Regional Medical Center, otherwise known as SRMC. I offer my condolences to the family, friends, and colleagues of former Senator Alicia Chucky Hansen. May God give you strength and comfort, and may she rest in eternal peace. I would like to thank this committee for the opportunity to provide testimony on Bill number 35-0119, the proposed legislation amending Title 19 of the Virgin Islands Code to add a chapter which develops and approves a mobile integrated healthcare program. Mobile integrated healthcare programs serve an important role in the healthcare system, providing care to some of the most vulnerable people in the community. The most common and valuable service models for mobile integrated healthcare programs focus on primary care and prevention. A mobile integrated healthcare program that focuses on primary care and preventative care can improve access to healthcare for Virgin Islanders. The mobile integrated healthcare program that is being proposed can help people in our community who are otherwise not able to access primary care to get the care they need, and it will help them get referred to and connected to clinical facilities like ours at SRMC that have specialty care and outpatient services. SRMC provides emergency care, acute inpatient care, specialty care, and outpatient services to our community, including rehabilitation, laboratory, radiology, and now behavioral health services through our newly established SRMC Wellness Clinic. We are currently increasing the specialty care we offer by adding gastroenterology and interventional cardiology. Yet we know many in our community still face barriers to accessing important primary care and preventative care and in getting referred to us at SRMC. We support the establishment or enhancement of a mobile integrated health program that provides primary care and preventative care and that refers patients to our system. It is also excellent that this program can offer support and in-home check-ins for patients who are discharged from our system who do need that support in their homes. As a small territory, even with the great work of our FQHCs, we are often impacted and somewhat challenged by the limited availability of primary care. We appreciate the efforts of this legislative body for giving attention to the importance of expanding access to care and for this proposed legislation that seeks to enhance primary care options for those most in need who may not be able to access this care through traditional channels. Expanding access to preventative and primary care will positively impact the overall healthcare system of the territory. It will help people get seen and screened earlier so they do not present to the hospital in an advanced state in their disease. It will also help to decrease the volume of patients who presently rely on the emergency departments for their primary care. We want to ensure access to the best care possible for the residents in our community. To that end, we continue to work in partnership with the Department of Health to close gap care, and we support initiatives such as these that work towards the expansion of primary and preventative care in the Virgin Islands. SRMC will be an important partner in accepting referrals from the mobile healthcare program when it is established. We know there are many in our community with cardiac issues, and we are bringing a very highly skilled interventional cardiologist to work alongside our excellent cardiologist, Dr. Sterling, to immediately intervene in the event of a heart attack, who can provide caths and stents and work on pacemakers right here within the territory. We hope that adequate resources and funding will be allocated for the important healthcare that will be provided through the mobile integrated healthcare program. Thank you for allowing me to offer support towards this legislation. Before I close, I want to take the opportunity to thank the entire team at Schneider Regional Medical Center for the amazing work they do for our community every day. Great things are happening at Schneider Regional Medical Center, and we encourage the community to trust us with your care. We've recently added gastroenterology services, and we want to encourage you to reach out to us for this important screening service. If you're 45 and over, we want to encourage you to come and get your colonoscopy done with us. We are here to serve you and to take care of you. And this important screening tool can help to prevent more advanced stages of cancers. You can call us at 340-776-8311, extension 2400, to make your appointment for this very important service. I want to thank this body, the Honorable Governor Albert Bryant, and the entire central government for your support of healthcare in the territory. The FQHCs, the hospitals, and Department of Health will continue to appreciate and lobby for and advocate for a fundamental shift in the priorities within the territory to ensure that good healthcare is funded and available at home right here on our islands. This concludes my testimony, but I am available for any questions that you may have. Thank you.
Thank you for the testimony, Tina Comisión. Ms. Nicole, I don't know if you had a separate testimony, or if not, we'll proceed to the next.
Oh, that's me. No, Senator, I do not.
Okay, yes. Mr. Evelyn, you may proceed, Fire.
Good day, Honorable Senator Ray Fonseca, Committee on Health, Hospitals, and Human Services Chair, all other members, and the listening and viewing audience. I am Lyle Evelyn Jr., the Assistant Director of Emergency Medical Services for the Virgin Islands Fire and Emergency Medical Services. I'm here to express our strong support for developing and approving mobile integrated healthcare programs in the Virgin Islands. We believe that MIH programs have the potential to revolutionize healthcare delivery in our community and address critical healthcare needs. Our islands face unique healthcare challenges, including geographic isolation, limited access to healthcare facilities, and a significant burden of chronic diseases. These challenges disproportionately affect the health and well-being of our residents, particularly those living in undeserved and remote areas. Mobile integrated healthcare programs offer a proactive, patient-centered approach to addressing these challenges head-on. The needs for MIH programs in the Virgin Islands are evident. Chronic disease management. Our community struggles with managing chronic diseases, resulting in high hospitalization and readmission rates. MIH programs can provide ongoing care and support to individuals with chronic conditions, reducing hospitalizations and improving their quality of life. Access to care. Many of our residents face barriers to healthcare services due to geographic distances and transportation limitations. MIH programs can bring healthcare directly to their homes, ensuring they receive timely and necessary care. Preventive care. Preventive care reduces healthcare costs and improves overall health outcomes. To keep our community healthier, MIH programs can focus on preventative measures, including vaccinations, screenings, and health education. Elderly population. The Virgin Islands have a growing elderly population that requires specialized care and support. MIH programs can cater to the unique healthcare needs of older adults, promoting their independence and well-being. Mental health support. Mental health conditions often go untreated in our community. MIH programs can incorporate mental health services, offering counseling and crisis intervention to those in need. The benefits of MIH programs are well documented and include improved health outcomes, reduced healthcare costs, enhanced access to care, patient-centered services, and positive community impact. By developing and improving MIH programs, we have a unique opportunity to transform healthcare in the Virgin Islands, address healthcare disparities, and create a healthier, more resilient community. We kindly request your support in advancing legislation and regulatory frameworks that facilitate our region's development and approval of mobile integrated healthcare programs. By working collaboratively with the VI Department of Health and other stakeholders, a framework can be established that ensures the safety, quality, and effectiveness of these programs while meeting the specific needs of our community. We are committed to actively participating in developing and implementing MIH programs and working with you to secure the necessary resources and funding to make this initiative successful. Thank you for your attention to this critical matter. We believe that mobile integrated healthcare programs have the potential to transform healthcare in the Virgin Islands and improve the lives of our residents. This concludes my testimony, and I welcome your questions.
Thank you very much, Leslie. Evelyn, Fire Director, is there any other persons that wish to provide testimony? If not, then the Committee on Health, Hospitals, and Human Services will stand in recess for 3 minutes. The Committee on Health, Hospitals, and Human Services is back on the record. Colleagues, we're going to do 5 minutes, a round of 5 minutes for all the senators, starting with Senator Blyden, Senator Francis Jr., Senator Potter, Carrion Gittins, Capehart, and then we'll have the bill sponsor. Commissioner Encarnacion, real quickly, I just wanted to go over the numbers with you. You're estimating it's about $1,253,000 more or less.
Sir.
Had you had a chance to run this by fire, and so that we can get all the numbers? Because you know, it seems to me that this here, once it's started, especially with the logistics on St. Croix, it's going to take a few more paramedics. But I'm comfortable with the numbers. I just wanted to get some input from fire, Mr. Evelyn.
Would you like me to respond or to? There you go.
Yes, you may respond. Yeah, Commissioner Encarnacion.
Thank you very much. And I also asked AD Evelyn to respond. The numbers that, as we're looking here, based on the actual numbers for our salary base for also the paramedics. So this should be actually congruent to what it's paid for right now for employees throughout the territory. So it should be no different. But of course, AD Evelyn can also respond to that. And if he doesn't have it in front of him, I know that Assistant Commissioner Nicole Cragwell-Sim has access to it. She can share with him as well.
Okay, because, you know, this program here, you know, it's hands down needed. In fact, it was needed several years ago. So I have to definitely commend the bill sponsor for moving this before the legislature. But it's never too late. Okay, so we'll start with Senator Marvin Blyden. Senator Blyden, you're recognized for your 5 minutes.
Thank you so much, Mr. Chair. Good morning to my colleagues, the listening and viewing audience, staff, central staff. Good morning, testifiers, and thank you so much for your testimonies. First, I want to thank the bill sponsor for bringing this legislation forward. It's necessary, and definitely I will be signing on as a sponsor also. The bill summary basically state the intent of the bill, which mandates the Department of Health to establish a mobile integrated healthcare program. And also what it does, it establishes the mobile integrated healthcare revolving fund and require the monies in that fund to be used solely by the Department of Health mobile integrated healthcare program. And finally, it mandates the Commissioner of Health to promulgate rules and regulations to administer this chapter. Now, I know all of the testifiers spoke in favor of this legislation, which basically, to me, is a no-brainer. I appreciate in terms of what it does. According to the East End Medical Center testimony, they spoke to unnecessary emergency room visits. It basically decreases the rate of readmissions, which are costly and can pose a risk to the patient. And also they spoke to meeting the patients where they're at. Because I know Frederickstead Health Clinic also spoke to that in respect to meeting the patients where they're at. And my question is, Commissioner Encarnacion, in your testimony, it caught my attention because you spoke to having to date on page 6 of your testimony. You said to date, we have enrolled 1,892 patients in this program, and currently you see 89 patients weekly. And this is on the island of St. Croix. My question is, though, you also spoke in terms of your concern with Pafford, and you also spoke to the Virgin Islands would be left without this needed service on St. Croix and would not be able to expand services on St. Thomas and St. John. So right now, this service is being done on St. Croix, but not on St. Thomas and St. John. Can you clarify that for me, please? First of all.
You're correct with that. We do have staff on St. Thomas for our EMS regulatory, and we were prepared with the funding available. We're prepared to begin the program. And also, I have the acting director here with me, so she can expound upon that if needed.
Please expand on that for me, succinctly, please.
Okay, can you repeat the question, sir?
Well, basically, the commissioner stated that it's being administered in St. Croix right now, but there's no program in this district. So I just wanted you to expound on that as to the reason why.
So the reason why was, like we stated in the testimony, again, Jacqueline Greenwich Payne for the record, the program was started in St. Croix. We had vision of moving it to St. Thomas, but we didn't have staffing. And so the program was really being done with our local EMTs combined with the Department of Health nurses and Pafford. So that was one of the reasons why we wanted to come forward and get the program legitimate and to be able to get funding so that we can be able to expand it throughout the territory.
Okay, very well. In terms of this program, though, I think it is critical because what it basically does, because I have a chart here basically showing how much it would cost, which is basically $1.3 million for both districts. And I believe it will save both hospitals in terms of uncompensated care a lot more in that respect. Let me actually
1 minute.
see Encarnacion for the Snyder Regional Hospital. How much how much patients visit our emergency rooms in this district and in St. John? About how much patients do we have on an annual basis? Can you recognize the mic, please? Ms. Encarnacion? Can you recognize the mic, please? Snyder Regional.
Tina Comisión, CEO, Snyder Regional. Thank you for the question, Senator Blyden. In our emergency room at the Royal Leicester Schneider Hospital, we see approximately 17,000 emergency visits per year. And at our Myra Keating Smith Clinic on the island of St. John, we see in excess of 6,500 visits per year.
That's a lot of visits. I know every time I pass there, it's full. So I think, and most of those folks do not have insurance, etc. stated, and it will help in that respect. Mr. Chair, may I conclude?
Yes.
In respect to my line of questioning, because Mr. Assistant Director Evelyn, let me actually respect, because the sponsor spoke to some funding that some $500,000 that was available that went to fire instead of going for this initiative. Let me ask you in respect to, well, I guess you wouldn't know because you're not a director, in respect to the funding and us basically seeing how we can, where we can tap into the funding in order to run these most important programs. Do you know if those funds were to be appropriated until expended, or those funds are already already being used, available until extended?
Larry Levin, Assistant Director of EMS. To the best of my recollection, those funds were never appropriated to us.
You never received those funds?
To the best of my recollection. I could be wrong, but I think for what I understand, it was reappropriated for other uses.
Purposes? Okay, thank you for that information. We'll do our due diligence. Thank you, Mr. Chair, for the time, and thank you for your responses. Thank you.
Mr. Chair, I'd like to add something to that.
Yes,
Senator
go ahead.
Blyden, I wanted to clarify that during COVID, in St. Thomas, St. John, we're able to send out many individuals to their homes as well. So vaccination testing was conducted from a mobile integrated system as well. Of course, funding after the state of emergency, we're no longer able to do that. So that's why this bill is so important.
Thank you so much for that. And I do agree with you. Thank you. The importance of the bill. Thank you.
Thank you, Senator Blyden. And I wanted to follow up with that, Mr. Evelyn, with the fire. Can you confirm two things for me? Were any of your staff injured where they had to be hospitalized during the fire for the last 3 weeks? And also, I want you to discuss in the future going forward if you believe that fire would need a greater capacity to be able to extinguish those fires at the Bovoni landfill, such as maybe a water source from the ocean or additional fire hydrants. So, Evelyn?
Larry Levin, Assistant Director of EMS. I need to confirm that because I was actually away for a week at an EMS conference, but as far as I know, no one was hospitalized due to the landfill fire. And I will also do a deeper dive in terms of moving forward, how we can provide better capacity for those type of fires.
Okay, thank you. Senator Francis, you're recognized for your 5 minutes.
Thank you very much, Mr. Chairman. Good morning to you, my colleagues. Good morning to the testifiers, and good morning to the people of the Virgin Islands. I want to first commend the bill sponsor for moving this this very important piece of legislation forward, as well as to thank all of the testifiers for their very excellent testimony, and thank you for taking the time to actually do your research and provide the information that's necessary for us to make a decision in this matter. I also want to commend the video testimony. Those were truly profound, and I thank them for their contribution. It's very moving for me. So I heard we talk about good health care, we talk about quality health care, and I just really want to say that this is what used to be done back in the days. We're just going backwards, right?
That's right.
This is what used to be done. My mom was a nurse, a public health nurse, and she was like the neighborhood nurse.
Yeah.
She was responsible for administering insulin and B12 deficiency, preparation, all these type of things. So it's just a matter, again, getting back to our roots and doing what we need to do. But I also took some time to look at the census, and certainly Commissioner Encarnacion provided some of that information as well in regards to the census. And if we're following the census, we have an aging community. And we truly need to focus in that particular area. So assisted living facilities and adult daycare and all these type of things is things that we definitely have to make a priority. You see, when we were putting this whole committee together, we came up with a super committee of 9 members for health, hospital, and human services, because we understand the importance and really wanted to hone in and what needs to be done to move the needle on this particular issue. And I know that we're making some inroads on that. And this bill is certainly one of those areas that we want to dwell on. But when we look at the uninsured, when we look at the underinsured, when we look at the median age of our U.S. population is 45.9. And when we look at the 21.3% of individuals in this community is over the age of 65. 1.8 is over the age of 85. We have our work cut out for us, and certainly we have to do our part there. But truly, I believe that what's been done, and Jackie Greenidge, you must get some of the credit in moving that forward in respect to the development of this going backwards to make sure that we're doing the mobile integrated healthcare programs is certainly commendable. You see, when you have to move individuals and get individuals that may be suffering from some type of illness to even go to the emergency room, it's a production. A lot of moving parts in preparation for that. Wheelchair-bound individuals, the cane, getting them prepared and attired and all kind of to get them into that vehicle actually to drive to the facilities in itself is a difficult task. So I have just a few questions. Of course, you're talking about utilizing the Emergency Service Fund that I created some time back in terms of at least increasing it. And I know that fund is under siege right now, where a lot of the services, the phone services and the numbers are really dwindling. We had that discussion just yesterday. So we need to be mindful of that, and perhaps I also look for an additional funding source to support this endeavor. But that'll be our responsibility. But is there any thought given to in terms of what is the protection for individuals, these nurses and these individuals, perhaps even the doctors, EMTs, when they go out to perform, how are they protected?
I'll start by saying that first means of protection is training and education, as well as the skill set that's needed and how you approach. I actually was speaking to the acting director during a break, and one of the things that she links with is our behavioral health team.
One minute.
If I may continue, de-escalation of technique is also important. So really, it's not just armory in terms of having guns or shields, but it's actually the armory of how you can actually present yourself, and remembering that when you go into the homes to help, people actually welcome you more. However, I think that it's important to be able to ensure that a physical protection is, I know as a former police, or once a police, I was a police, but you think about that. So I'm going to ask the assistant director to speak more about what they do currently in terms of how they protect themselves.
But I want you not just think about the physical protection, but more so the protection from anything that they may administer in respect to that. That's kind of what it would.
And I can speak to that from a nursing perspective. It's called universal precaution. And so no matter what you do, first of all, bloodborne pathogen training is actually administered by the assistant director. So actually that's not just for the individuals who go into the homes, but for the people who come to actually seek care in the Department of Health. That's a mandatory standard that's retrained on an annual basis, how you protect yourself, which PPEs you have to use, and how you care for the patients as well.
Very well. So they don't have to be forced with this cloud over, making sure that they're protected from lawsuits or liability or anything like that.
Right, and we actually spoke to that yesterday, not just about the paramedics or the program, MIH program, but also about our community health workers, because you said go back in time, we now have community health workers that are certified in the Department of Health, and they are going into the community, into the homes, as well as being protected through our medical malpractice and what we do.
Very well. Mr. Chair, if I may just wrap up with one quick
Yes.
question. And in respect to the demographical data, are you keeping a separate file? What is the reporting mechanism or documentation, data collection that's been done in this area? And if you could talk about commonality of care, is there any trend that you're seeing in terms of chronic disease or the type of open wounds? If you could just touch on those two items.
Okay,
I'll appreciate
I'll
it.
have the acting director speak to that.
Good morning, Jacqueline Greenwich Payne for the record. And I just want to touch a little bit quick on when the team goes out, nobody goes out by themselves. It's a team of 3 individuals that goes out in the home. What we're out there looking at is cardiac issues. We do have a lot of cardiac patients. We also have patients with COPD that we're taking care of. Is chronic pulmonary obstructive disease of the lungs. Diabetes, high blood pressure are really, really big out in the community, along with the decubitus ulcers where we're treating the wound care. So those are the big items that's out there. But one of the things that the team does do when we go out, for the diabetic, we get the disposable A1C kit. So the patient would fast, and then when we go out, we can see what their levels are and if they're within the right level. We do have cholesterol machine that we test the cholesterol for those who have high cholesterol. We do their blood pressures. For those who have cardiac problem, every visit we'll run a 12 lead and see if there's changes and focus on their diet. So it's just a total wraparound program in terms of safety, educating them. And the good thing about being in the Department of Health is we're able to connect them to the service within primary care, because you would be surprised, 90% of the patients don't have a medical home. So we've been using the primary care division within the Department of Health as those individual primary homes, so they get extension to other services.
Thank you, Senate President Francis. I wanted to follow up on that, right? Because the Health, Hospital, and Human Services Committee is the only super committee in the 35th legislature. Of course, the president chaired that committee in the last legislature. But, you know, I wanted to discuss the elderly comments, right? Because, you know, last week, the 35th legislature, we approved Bill number 35-140, which was the Cigna Health Insurance. It's $183 million. And, you know, of course I voted for it because, you know, the timelines, it seems like they always bring it to us at the last minute and with force. It's like the gun is to your head. If you don't approve this, thousands of employees, you know, lose the insurance. But, you know, I am disappointed with how they're treating the retirees, you know, because right now, the employees of the government get an automatic $10,000 life insurance, and the retirees, it's only $5,000. And it should be, to me, it seems like it should be the opposite. The retirees would more have a need for life insurance because, you know, well, they're retired. We don't want anybody to, you know, nothing bad to happen. So I'm not satisfied that the retirees have half the amount of life insurance. But in addition to that, right, the retirees are on a fixed income. And that $500 deductible that they have for the retirees, I don't agree with that. There should be no health insurance deductible for the retirees. And, you know, I added up the numbers, you know. I don't have a PhD, but I could add a little bit, you know. And it's $183 million. We received testimony that off-island is $56 million, 345. On island was 62, and then they say Puerto Rico was 26,000. I find it hard to believe only 26,000 in Puerto Rico, but I'll take the numbers. I added it up; it comes up to 118 million. Remember, the contract is for 183 million, so there's $65 million left. Where does that $65 million go? Is it costing us $65 million to operate our government insurance? You know, so I'm concerned, but I am not happy with the retirees being treated like how they are being treated. Next, we'll go to Senator Potter. Senator Potter, you're recognized for your 5 minutes.
Thank you very much, Mr. Chair. I am definitely in supportive of this bill that's before us today, bill number 35-0119. I definitely want to give my kudos to the bill sponsor for really having the foresight for proposing this bill. I think it's a no-brainer, and I think this is one of the few measures that come before us where there is 100% consensus among the testifiers as well as my colleagues. But I wanted to, it definitely is an opportunity for us to, as the presenters said, so prevention of unnecessary ER visits can lead to a reduction in the rate of admission, reduces 911 calls, and there's a focus on prevention, catching things on the front end as opposed to letting them escalate to more serious illnesses on the back end. But I wanted to ask, just in terms of ambulance calls, and I don't know if we have the this sort of statistical information, whether it is the hospital or the Department of Health. Do we have any ideas as to what percentage of these ambulance calls are, I guess, are unnecessary calls? I know that's something that the hospitals or the Department of Health or the EMS struggles with, you know, trying to ensure that, you know, ambulance services is properly utilized. Is there any way for us to track whether or not, you know, track the numbers as to what percentage of these calls may be unnecessary?
Lyle Evelyn, Assistant Director of EMS, VI Fire and EMS. Yes, we do track these calls electronically, and it's also a requirement for us to receive specific funding for that. So I can say this, but you know, nationwide or even here, only about 20% of the calls we go on require advanced care.
Okay.
So, advanced care meaning the care of medications and defibrillation and stuff like that. So most of the calls are fairly routine, factor in an occasional gunshot wound and stuff like that. But most of the calls are medical, and of those medical calls, only 20% require the care of advanced life support provider.
That's interesting. That's significant. That is absolutely significant. And I see this program as really assisting with this. Now, the way the program works, is it a physician referral program? Is there a way for potential clients to sign up for this program? How will it actually be implemented, or how is it implemented on St. Croix? Because I understand that the program currently is functioning on St. Croix.
This is Commissioner Encarnacion. There should be some referral system so that we can indicate what the criteria for admission to that is, or we could have a lot of people signing up for the program, but right now it's more a referral. So that means that these individuals have been discharged from the hospital or seen by a primary care physician and linked to the program. Right now, is there anything else that's been there?
Also, we allow the ambulance services to make referral. So for instance, if they go to an elderly home twice in a week, that paramedic or EMT can make a referral. And that's how we reduce the elderly or non-urgent calls, because then the MIH team will go out after getting a referral, visit that person and see what their needs are. Because we do get a lot of calls for, I fall, I can't get up, or they're hungry and they need care, they're in a bad way. And so we will go out when we get those referrals from 911. And many of them have been admitted to the program.
Okay, I know we had the health insurance folks before us a week or two ago, and UHC in particular, they were talking about a special program that they had, which is similar, but I think a smaller, a more scaled down version, where physicians or nurses, not physicians, but nurses would actually make home visits. And what really surprised me was he said that in the Virgin Islands, our rate of participation in that program exceeded the national average. Typically, we aren't, so quick to embrace some of these programs, but the program is really functioning in a massive way here in the Virgin Islands, which is good. I think I had another question. The model that is being proposed. Now, I notice, Commissioner Encarnacion, your model calls for, I think, licensed practical nurse, a registered nurse, a paramedic, a EMT, and I believe a nursing practitioner. Is that the typical model for these programs?
I'm going to ask the expert to speak to that.
Greenwich Payne again here for the record. Each territory, each state developed their model. And so the model that we chose was to have a nurse and a part-time nurse practitioner, which we work as the extension of our medical director, because we're going to join a paramedic and a nurse together, because the nurse are able to get into the pathophysiology because of their training, and able to educate the family members on the disease process, be able to write care plans. The paramedic works with them, and then they would kick in when there is an emergency. The nurse practitioner now are able to help us in terms of critical care in that field, and be able to write prescriptions so that we don't have to be going back and forth to these patients, that when we go in is a complete care and everything is done one time.
Okay. So if there is an emergency call, so would the unit determine who is dispatched for that specific call, or is the team dispatched collectively?
So our team is not dispatched through 911. The MIH team worked separate from the 911 side when EMS was in the Department of Health. So the whole mobile integrated team is a whole different team separate to the 911 side. Because when we go in the homes, if there is an emergency, we would stabilize and then we would call for the ambulance if the ambulance is needed. But it's not the ambulance going out to take care of the patient. It's the created team of the nurse and a paramedic and an EMT that is assigned to that team, and they would be the one going out to provide that care. It never came from the 911 side to affect the 911 side.
I got you. Is ultimately, I believe my time was called, but this is my
Yes.
final question.
Yes,
So
you may
if-
wrap up, Senator Pata.
Thank you, Senator. So if a 911, is it the goal ultimately for, this program to be sort of directed through the 911 call center, where an emergency takes place and the dispatcher determines, well, I don't think we need a ambulance to go to, the home to bring that person back to the hospital, but this may require the mobile integration team to be dispatched to provide some sort of a different type of care than, would be required from a 911, a typical 911 ambulance call. So I'm just trying to understand how the program ultimately, I know Director Joshin was here this morning, spoke earlier. Is it ultimately our aim to make this all be a part of one consolidated 911 call center operations initiative, and the traffic cop, so to speak, determines exactly who is dispatched?
Point of did anyone want to respond?
Well,
to
we can
Senator Pata?
respond. We can respond.
Point of information, Senator James, you're recognized for your point of information.
Thank you, Mr. Chair. I think this is the best time for me to perhaps respond to Director Joshin's concerns. There are 911 triage, nurse triage lines in different jurisdictions. So I included it, and that's why it says MIH components include traditional, and it goes on, and it says 911. It doesn't mean that we have one right now. We do not have that program. But I'm thinking ahead in terms of, one of the things I'm actually piggybacking on Ms. Greenwich Payne's vision. So there may be a time when there's nurse triage lines. There also, that's the reason why that's inserted. Also, when you said that activated 911 system, it's because, as Ms. Payne just eloquently said, there are times when the MIH program participant may need to call 911. So there has to be that connection. And then when it comes to the department, I think you talked about the triage assessment tools. That's really for the Department of Health to determine whether or not they want that incorporated. But I didn't want to exclude it now and then later on have to come back to the legislation and have it amended. So I hope that answers the Senator's questions, because as Ms. Greenwich Payne says, it's two different programs, and I think she can expand on that a little more if you need her to. But there's always the connection. You can be treating somebody, even in a doctor's office, he can be treating someone and need to call 911. I don't know if it assisted. Thank you.
That's good enough. Thank you very much.
If I may add,
Yes, you may.
one of the things that's going to help with that as well is the data collection that the senator spoke about earlier. And if you have that, you can more easily track exactly what you're going out to look at.
Okay, thank you, Senator Milton Potter. Before we go to the next Senator Carrion, I wanted to just go back on that with the insurance again, right? Because remember, I told you the government it's $183 million, but 56 million of it is going off island. Of course, I'm not, disencouraging anyone to visit Cleveland Clinic, Mayo, et cetera, But I wanted Tina Commission for you to give me some clarifications on why is it that the VA government health insurance plan, the way how I understand it, why can't they waive the co-insurance fee, so that we can have an incentive for people to remain here and do those procedures? What's the reason behind that?
Tina Comisión, CEO for Schneider Regional, and thank you, Senator, for the question. Our position is that we provide great healthcare, excellent healthcare. We have top-notch providers right here in the Virgin Islands practicing at Schneider Regional. We offer an array of services that folks choose to leave island to get care for. We want to continue to build the community's confidence in what we do offer, and for things that can be provided on island, we want you to stay here for your care. We think there are ways to incentivize people to stay here for their care by changing the insurance product. So if there's a way to, right now you can use your plan and not pay any copay, co-insurance. It's the same if you get treated here or if you get treated off island. As we continue to improve our services, we want to hopefully change that. So you do have to pay a little bit more if you choose to leave island for care that we provide here very well. So if you want to choose that, it's most health insurance plans have that. If you want to stay in network, you get the benefit of reduced copays, et cetera. We waive the copays completely. If you choose to go off island or out of the network for your care, then you have to pay a little premium on that. And we think that's good overall for the entire community because it is that reinvestment and it is the use of our health insurance products here within our emergency room and throughout our system that then gives us enough financial stability and enough insured patients to take care of the other vulnerable people in our community who don't have any insurance products. So we want to improve our payer mix. We want to keep Virgin Islanders at home for their care. And truly, we think you get as good or better care here than anywhere else. Our doctors are all US trained, board certified. They live in our community. They care about our patients. And we really constantly focus on quality and safety, and we think it's a great place to get your care here. It's good to have the support of your family while you're getting care. And so we want to create incentives for Virgin Islanders, especially Virgin Islanders and government employees with Cigna Insurance, to choose to use our system and thereby support our system in a way that it serves the entire community. Thank you for the opportunity to present that.
Okay, good. So you're hearing it from Tina Commission herself, and I'm sure Doug Cook would echo the same thing, that there are procedures that we can remain in our territory close to our family and get treated. I'd like to recognize the presence of Senator Javon James. Thank you for attending, Senator James. Next, we'll go to Vice Chairman Senator Gittins. Senator Gittins, you're recognized for your 5 minutes.
Thank you, Mr. Chair. I wasn't quite prepared. I thought you said Senator Carrion was next. But
yes, I did, but he stepped out momentarily.
All right, so let me see where I could jump in. So I heard the Senate President earlier, and I said he could see my notes over here and on this end as he spoke to back in the day. And Department of Health knows that I am always talking about back in the day when it comes to public health. The public health that I once knew when I ran around SLAB and the old Charles Howard Hospital and wherever else they were. But I'm happy to see that we're getting back to basics. Because again, as a child growing up, every time you turn on the television, you could see some public service announcement from the Department of Health when it came to dental health, being vaccinated, etc. So I wholeheartedly applaud what's before us. Let me ask, on page 4 of the bill, line 19, the Department of Health, I see, is responsible for developing and approving the mobile integrated healthcare program. Obviously, based on the testimony that we heard today, the process of developing and approving has already begun. So am I correct to say that, Department of Health?
The development portion is yes.
Right. So how long will it take to see the completion of the program to the approval stage?
That's what we are, even though the regulatory bill hasn't come to the Senate yet, we are responsible for regulatory within the Department of Health. And as Acting Director Greenwich Payne is responsible for regulatory in that area as well. So she links with the National Center for EMS in reference to all of the regulatory requirements, and she can speak more to that.
Okay, you give me the long answer, but okay. I just wanted to know a time frame. Just a time frame.
Well, I'm telling you, in a year, once we get the funding, because as I have holding here in my hand, this is the whole write-up and the establishment of the program and all the care that goes on.
A year?
Yes.
So 1 year? Okay.
Yes.
You know, when it comes to Jackie, I am afraid, that's why I asked an pointed question. However, Commissioner, and the fact that you refer to her as acting director just now, and when she introduced herself as acting director. Why is she still acting at this time? And we are so dependent on her services. Is that being addressed?
Let me just say that, just for you, Senator, we have a fact sheet on Jackie Greenwich Payne, so that you know that we've really been working over this last year and getting her to where she is. So all of our past, whatever she was acting, has been solidified. Right now, the director's role is on the 2024 budget. So as soon as that's open, everything has been fixed, and she will be stamped as the director of EMS regulatory.
Jacqueline Greenwich Payne, congratulations in advance. Hopefully the next time you come before the Senate, we're not referring to you as acting
1 minute.
Acting anybody. I also see that the program requires paramedics. And since the program will be under the Department of Health, how many paramedics do you currently employ? And how many would be required for this program?
You want to go to that? Go ahead.
Right now, we have, that's remaining back with us, we have one EMT that goes out currently with the nurses to complete the MIA visits.
Jackie, my time gonna run. I just want to know, how many paramedics do you have, and how many will require for this program? Just paramedics.
Okay, we don't have any paramedics right now. I fill that role. If they need a paramedic, we would need 2 paramedics for each district.
1 minute. Time.
2 paramedics for each district. Mr. Chair, may I conclude?
Yes.
So 2 paramedics for each district. So Jackie, you see why I don't have to cut you off in that I want to, but the time that runs so fast. Let me ask the last question. Page 5 of the bill, the measure also speaks to providing pre- and post-hospital services. I can't help but to see the absence of our St. Clair Hospital representatives today. what is your communication and collaboration like with both hospitals regarding the pre and post hospital services that the bill speaks to on page 5? Department of Health.
In terms of with the hospitals have been making referral to our program for patients that were critically ill that's been discharged so that we can continue that care. Because under the CMS regulation, if a patient been in the hospital and been discharged and returned back to the hospital within 30 days, then CMS will not pay the hospital for the services that the patient received. And so they refer those patients or patients that have critical needs. So that's how we do that service in terms of pre and post.
So I'm asking, what's your communication and collaboration like with them? You have a good open communication with both hospitals so far?
Well, we haven't extended to Snyder. The only communication we have with Snyder is through our EMS for Children program. But on St. Croix, where we're doing the mobile integrated healthcare, we have excellent communication with JFL.
So I will encourage that communication and collaboration with both hospitals, and ask that you also get from both hospitals discharge protocol from them, one that's in writing. Thank you, Mr. Chair, and I look forward to supporting this measure. Thank you.
Thank you, Vice Chair Gittins. Before we go to the Honorable Rules Chair, I just wanted to ask the Commissioner of Health. I was looking at the number, right, and I notice here you have one registered nurse on St. Thomas at 70,000, and I believe, check with your staff or Office of Collective Bargains, but I believe now the minimum for RN is starting at 75. But then just to be consistent, you have two nurses on St. Thomas, that was 170,000. So right now you got 85,000 for the nurse on St. Thomas and only 70,000 on St. Croix. So let's just be consistent, or can you give me an explanation
That's
on
an
that?
error.
That's an
an error.
error?
That
Okay.
will be corrected and
Okay, yeah,
resent.
thank you very much. While we're talking about the nurses' salary, have we paid the nurses their new grade and step? What's the update with the nurses now?
Most of them have gotten paid, all of the ones who actually are paid through general fund. So we're working right now on getting the federal funded paid. We went through the list yesterday, actually acquired something from our Human Resources Department and where we are. So I have a stage as to how they'll be paid. And I asked them to ensure that the nurses are aware of what the process is and the length of time before they have their increases.
So do you have a date when the nurses will be paid, more or less, this
They're
month?
all going
next?
through the process right now, but from a federal standpoint, once we know we have access to it, then it'll be done. So we're hopefully close, and as soon as the budget is open again, they should be able to be paid.
Okay, so
The key thing is communication, and we're going to keep in contact with them so they know.
Okay, so I think that means nurses that they're working on it, but they ain't have a final date yet. But anyway, it's a good progress that most of the nurses have been paid because, as you know, nurses are very critical to the operation of your agency.
As I know, yes.
Yes, blessing. Senator Diane T. Capehart, you're recognized for your 5 minutes.
Thank you, Mr. Chair, and good afternoon, colleagues. Good afternoon, testifiers. To the people of the Virgin Islands, blessed good afternoon. I have to say, I'm definitely in support of Bill number 35-0119. Just while this meeting is going on, I told my colleague that you preempted me on this bill. And I just want to say that this bill is a bill that is well needed. Sometimes it's a good idea. So who gave first, colleague? You've been championing this, as you've told me, for a while, and I'm going to sign on to this legislation because it's well needed. I look at it as healthcare anytime, anywhere, but as time hearing, I wanted to first ask, what would be the hours of this mobile van?
I'll start by saying that it's during the day because it's not an emergency service. So that's why it's actually planned and it's scheduled. In that way, and unless, and like we said before, when you go to the home, if there's an emergency, then of course you activate that. But
Right.
it's 8 to 5,
Okay.
sometimes extended hours because the team always works after hours if need be.
Yes, yes, we know that dedication from that team. And I look at this as, would this help to reduce costs for patients and for the healthcare system?
It's identified, yes, from, for example, prevention. Once you talk about preventive care, you actually reduce the cost. Preventing hospitalization, treating them at home, first of all, they're more comfortable, as that had been identified before, but it prevents emergency room visits, which can be very costly. It reduces ambulance visits or ambulance calls, emergency room visits, because you have to pay separate for that,
Right.
and hospitalization. And if it takes too long, then the hospitalization is longer and the recovery is longer.
Great, so it's definitely a win-win system for our healthcare system. What about data privacy? Privacy as for our patients that would come to this mobile van?
Everyone, it's not a mobile van, it's actually going into their homes. But everyone that works for the Department of Health signs off on HIPAA confidentiality statements, validating that they are trusted and your information is trusted with them.
Okay. Okay, so that when you say the word mobile, it's like I was thinking a van. So thank you for that clarification.
Doesn't mean that cannot happen, but
So if I may, do you have a mobile van that goes out in the community?
we have several mobile vans that goes out into the community.
And I know you didn't come here for other things, but it's up and running?
Yes, they're all up and running. We have, if I may, we have behavioral health vans and within both districts. We have community health vans and we have MCH vans for the children, and we have an emergency vehicle as well.
Well, that's good that you talked about that because Senator James, who's sitting next to me, we were talking about if there was going to be any expansion of services for behavioral health. So you saying you already are addressing that through one of your outreach vans?
The legislation, and I cannot say the year of the legislation, Senator Francis would be
1
able
minute.
to, but he actually sponsored a bill that allowed for, and please correct me if I'm wrong, allowed for the mobile van for behavioral health. And so we
Okay.
actually are out there. I have to tell you that our behavioral health van actually was stood up right next to where the fire was, close to, in the Bovoni area.
Uh-huh.
So it actually provided physical care, but also we were available to provide emotional assistance if needed. So between EMS and the Department of Health, we were able to help them.
Great. So, when I look at this, I'm saying that this would definitely help the underserved population through medically or even socially who tend to have a higher risk
Right.
of health issues. So I'm in support of that. Lastly, Medicaid, Medicare coverage, these individuals would be able to also get the same benefits
Time.
as this mobile care, correct?
Of course, the Department of Health is certified to bill for Medicare, Medicaid
Okay.
as well.
Okay. Thank you. Thank you, Mr. Chair.
Yes, thank you very much, Senator Capehart. Ms. Sproul Webster, I just wanted to follow up. I was, looking at the testimony with the syringe exchange program. One quick question, and then I want you to answer something else. Do we also do do we also still do the free condoms, or is that no longer
That's a
being
great
done?
question because we don't speak about that often. It's always a squeamish, and for some reason, our communicable disease division, they hand out condoms everywhere they go, as well as not only hand out condoms, but we conduct testing. We conduct testing along with COVID testing, but we do HIV testing. We are still higher in our numbers in terms of our numbers that we have within our territories comparatively. So we are pushing HIV reduction by 2030. So basically 340, getting to zero by 2030.
Okay, thanks. Ms. Webster, so give me some more details on your syringe exchange program, because I imagine that's very important for the underserved community.
Yes, we have a division of community and social programs where the emphasis is on harm reduction and trying to stop the spread of HIV and AIDS. And we believe that syringe exchange is one of those efforts to stop that reduction. They go out into the various communities where we know people use syringes, primarily for drug use. Though some are for medical use, but for drug use, and we are giving them clean syringes for old or their used syringes, so that they are not using the same syringe and giving it to friends and other people using, and again, this would cause the spread of the HIV virus. And as the commissioner said, we also do condom distributions. We have about 100 businesses in the community that have allowed us to put dispensers in their facilities where we have free condoms. We're constantly there refilling these dispensers so people can take as much as they want whenever they want. And also our team, when they go out on outreach activities, they are also giving out condoms. And in all our facilities, we have jars and containers with condoms for people to take as they need.
Okay. Before I go to Senator James, one follow-up question. So you said it's a syringe exchange, but suppose someone presents themselves and they want a syringe, a needle, we call it. Would they be able to get it?
Yes, we'll give it to them. Yes,
Okay.
we'll give them several of them, yes.
Okay, thank you very much. Senator Carrion, you're recognized for your 5 minutes.
Thank you, Mr. Chair, and good afternoon to the testifiers. I want to commend the author of this bill because I think it's much needed. We clearly heard in the testimonies today that was presented how this will improve, and we're talking about our whole health care in the territory. Prevention is the key, and if we could also be able to assist to avoid unnecessary visits to the emergency room, and also just assist our community. Like we said, we have a Asian population that needs assistance, or anyone, you don't have to be Asian, you might need some support. So I stand in support of this measure. I think it's much needed. I do have a few questions. I was asking the sponsor of the bill a bit about what was going on and the intention with everything. So I understand. So the program is in place right now. So it's kind of like a pilot program that you guys have.
It's more of a pilot. It's actually an active program, that started in 2017 after the hurricanes, and has actually been able to, because of someone as strong as Acting Director Greenwich Payne, been able to keep it going.
Beautiful. But you're not in St. Thomas yet.
Correct.
Okay. So that's why it's still in its infancy stage. That's why I kind of call it a pilot program, that because it's in development stage. And what this does now is codify it and ensures that you have the proper funding and everything in place to move forward. Full swing. Beautiful. Currently, the staffing, I see you presented in the testimony what the staffing would look like and what the budget would require for that type of staffing. What is that amount?
We have to make some changes to the budget, but right now it's 1,253,985.
Beautiful. And that wasn't appropriated in this budget cycle for FY?
No, it wasn't.
No, it wasn't. Okay. So that's something additional that we would have to be able to appropriate now if it's going to be effective 120 days after it's enacted, right? So that's something we have to look into. So what partnerships and collaborations are being considered to support the implementation of MIH program in the Virgin Islands?
Speaking about the third parties, because actually made sure I called the assistant director, acting director, to speak about that. But we spoke about that here today. Both hospitals, of course, the federally qualified health centers, and our private providers. We heard a testimony from Dr. Owens, who spoke to that. She is not only, she has her private practice, she also works at the hospital. So any discharged patients, emergency room physicians. So I think there's a whole range of individuals, as well as our private practitioners, who sometimes tend not to be linked to these, but as Dr. Christian spoke about, they have insurance, they seek private providers. However, the need for mobile integrated healthcare came to them as well, no matter who you are.
Thank you. So how would all these systems work in that unity? Are you planning to establish some MOUs with the hospital? Is there a system in place that you would know when someone is discharged and might need some follow-up assistance? Would the individual need to require and apply to be able to receive this help? Explain to us how would this look like?
There's definitely going to be a criteria, and we could go to the details, but I'll allow us acting director to speak to that a little bit more.
So right now, what's happening is we have a relationship with JFL Hospital. So when they're going to discharge the patients, we go over and meet with them. They give us a copy of their discharge summary, and we speak with their family member, and then we make an appointment with them, get directions to go to their homes, and then we fill out a form that admits them into the program, and we develop a specific care plan for each individual patient. So not only patient with critical health care, but if there is patient with decubitus ulcers like wound care, they'll also refer them to us. We have gotten referral from Frederiksted Health Center, from ProHealth, and individual doctors. And it's really, I'm telling you, everybody just love this. It's good communication. And even those who have patients that were referred by a family member, we go with them to their doctor appointment so their doctors could know that, hey, the mobile integrated healthcare is taking care of that patient. Do you have any specific care that you want to add a care plan for us when we go to that individual home? Thank
Beautiful.
you.
And just closing, Mr. Chair, if I may, Commissioner, are there opportunities for federal funding grants to be able to support this program?
Of course, from the public health standpoint, we can seek grant funding. We are waiting. Hopefully, we can get our higher resource. We are hiring a health strategist who is going to be responsible for researching grants, and that's one of the tasks that she will be given.
Good. Beautiful. Well, I stand in support, and at the appropriate time, I'll be voting in affirmative, and anything that we can do to ensure this program is successful because it's much needed in our community. Thank you very much. Thank you, Mr. Chair.
Thank you, Senator Samuel Carrion. Next, we'll go to Senator Javon James Sr. You're recognized for your 5 minutes.
Greetings to the people of the U.S. Virgin Islands. Thank you, Mr. Chair, for the time. I am not a member of this committee, but hey, what can you do? Just show up to work. I also want to say happy birthday to the chairwoman of the Committee on Budget, Appropriations, and Finance. I wish you the best on your birthday and enjoy it. Don't think about work today. But as far as the budget, I saw the budget that you presented, Commissioner Hussein Kanasiong, and my question to you is, these individuals will be working between 8 to 5 or all around the clock?
It would be really 8 to 5, and sometimes an extension in the evening hours if need be, but it's not going to be around the clock because it's really more for, it's not for emergent, it's for more chronic cases. So that allows us to do it more daytime.
Because my question would have been, have you factored in the need for overtime, night differential, or just in case you might have to have some exceptions? I'm not sure. You're the expert.
We can always add to the budget in terms of, I'm just teasing, but that overtime is always factored into from a general fund standpoint on an annual basis. But I agree with you, we would have to factor those in because there's sometimes when you go to a home, you may stay longer than you actually expected.
Yes, because if you get a call at 4 and the person ends at 5,
Right.
you can't just say, well, I have to go home. You have to deal with it. So I'm hoping and praying you already have a formula to take those things into consideration.
The percentage, yeah, that would be taken into consideration.
Okay, hopefully, because every life counts. And as far as hazardous pay, they will not be receiving hazardous pay, right?
Unless there is a behavioral component, and as the director has indicated, behavioral health situations do arise, and our behavioral health team, when they go out with them, they do indeed get hazardous pay.
So how you go about justifying that if those situations arrive? I guess based on the reports or the
The
incidents?
reports would, that would definitely do it.
Okay, and to you, Acting Director Jacqueline Greenwich Payne, the next time we see your face here, we want to call you Director. Because you're not acting, you have been doing a lot for this community, because you have some people who are not acting and they ain't doing what you're doing. But that's a whole nother story. But as far as the organization chart, can anybody explain to me what was used to come up with this structure? Was it something that, is it something that you're still working on? Because I know it's always room for growth. How long have you been working on this organization chart to come to present us with this here today?
Go ahead, Director.
The organizational chart has been established from the time we started.
What
because
year?
2017.
Okay.
We are an extension of the medical director. So everybody that works on the team reports up to the medical director, and then he goes up to the commissioner. So that's how the organizational chart came about when we started. And I don't know if you can see it, but we also send.
So 1 second. So since the inception, you have never altered or changed it. This has been the original organizational chart.
Yes, sir.
Okay.
But also, we did send out so each member can see that this has been here also from 2017. This is a write-up of what our objectives are, what the job role is for the paramedic, the nurse, and all of the care that we're going to give for the diseases or processes that we're going to be dealing with. So you can take a look at that also.
No problem. When I'm not a member of this committee, like I said, I'm not a member of the Committee on Rules and Judiciary, but when it comes to the full body, you can count on me for your support and to vote for this. But my question is, I'm not sure if I'm seeing a disparity, but I'm seeing a registered nurse of 170,000 in the St. Thomas St. John district, but I'm seeing a registered nurse of 70,000 in the St. Croix district. That was a mistake?
Yeah, that was an error. We identified not only that, but we do have to have fringe and benefits added to that. So we will be adjusting and resending.
Okay, no problem. Well, everything seems to be good here. The only thing I'm concerned about is the bill speaks to not later than 120 days after the effective date of this act. You know the rest. You have to put those things in place. Is that more than enough time, the 120 days?
We would be activating more the St. Thomas, St. John district. And I think that that would be enough time for recruitment and placement.
Time.
No problem. Mr. Chair, with your indulgence, I just have one last question.
You may.
Data. I know one of my colleagues touched on it briefly, but as far as your organizational chart and the structure of what you have here, who will be in charge of collecting this data? Is there somebody going to be contracting, or is it going to be internal?
The program manager is who's going to be responsible. There is, we had a trial basis of EMS, MIH data through Zoll, the same EMS charts that we've been documenting, and we had a trial basis. And so now all of that information is in that database. And since they expire, we do have physical charts, and they're protected by HIPAA and they're under lock and key, but we do have that data, and we can go back and look at it, and we could see how many patients we saw. We could break it down as to how many are diabetics and stuff like that. So we do data. Everything is driven by data.
The reason why I'm asking that, because I hope and pray one of these days we really maximize the use of the University of the Virgin Islands, where we can have individuals create a think tank and study all the different data that we have in the territory regarding healthcare, so we can find out the future of healthcare, especially if you speak about a 2040 vision plan. So with that said, Mr. Chair, I just want to say thank you once again. I remember the time I had the thing in my eye. You remember that, right? And I was bawling like a baby, and I came to you and you took it out. We need more people like you, so thank you for all that you do for the people of the U.S. Virgin Islands.
You're welcome.
Chairman, may I add something?
Yes,
It's important to identify for the community that we actually worked on a community health assessment and developed a community health assessment plan. It's called Healthy VI 2030, and it's actually on our website. So you can actually look into that, and that is one established way of identifying what our challenges are and what we need to do in the future.
Okay, thank you. And thank you, Senator Javon James Sr. I just wanted to remind my colleagues on St. Thomas that after we finish with the testifiers, we are going to delay the vote, but I need you to be back by 1 o'clock so that we can have everyone present on the St. Thomas end to vote. I saw your messages where you want to get lunch. So real quickly, I will now go to the bill sponsor, Senator Maurice James.
Thank you, Mr. Chair. First of all, I want to say that sometimes innovation comes before legislation. And that's what happened with Department of Health and what you've done with this particular program. You came up with it, and then now we need to make sure that we are making it formal, legitimate in the sense of being codified, because it is legitimate. It's a legitimate program, but it also allows, as my colleague here said, it allows you to apply for federal grants, and that's important. I wanted to share with everyone that while I was researching this, I found out, which is interesting to me, that Uber Health is the unofficial leader of mobile integrated healthcare in the United States. They actually got into this by having their riders take nurses to vaccine people, prescriptions. Talk about business getting into something like this, which I found amazing. The other thing, where nurses would go out and give, they hired nurses with Uber riders, and they'd go out and give flu shots, just things like that. I also came across another one that served, again, it comes down to community needs, and I think in our community, aging population is in fact one of the groups that we have to focus on. And it's an evolving industry. I wanted to ask the CEO of Snyder Hospital, while sitting here, I don't know, I'm just asking, do you think a program like this would put a dent in that issue that we have with borders if people knew that? I really don't know the reason why we end up with borders, so maybe you can speak to that first. But I was wondering if maybe people knew that we have programs like this, if it would help. Just your opinion and how, if that's possible.
Sure, Senator. Thank you for the opportunity to speak on it. This is Tina Cummins-Young, CEO for Schneider Regional. I think the program will help us with the border situation that we have. There are a number of contributing factors. At times, vulnerable patients are not getting the care that they need to maintain themselves in their homes, and so they come to the hospital in a very critical state. and then we're not able to discharge them back to their home because there's not appropriate care. And we know, especially in our district, there's no skilled nursing facility. There are very, very few nursing home beds. We're limited to just a few in Queen Louise. And so right now the hospital has 9 boarders, which at the Medicaid rate of $1,352 for those 9 boarders, it costs the hospital $365,000 per month in care, which annualizes to $4.38 million in care to boarders. We know there are a lot of vulnerable elderly people at home who are really on the edge of coming to the hospital and becoming boarders. And so we think putting this program in place that helps to keep the aged and vulnerable populations more healthy in their homes will help us to not have to receive them in the emergency room and not have to admit them and then not have the difficulty with the discharge. But as a territory, we really have to put some resources and effort into discharge options for the hospital for these patients. And until we can provide that care, that skilled nursing home care in the territory, we're going to have to continue to expand contracts to take care of these patients elsewhere. The hospital is the most expensive bed in the territory. We currently are really saddled by the number of boarders that we take care of. So thank you for the opportunity to speak on it. And we're really hoping for a change for this population. Thank you.
Thank you. I actually was shocked by your answer when you gave the figures. I had no idea of the amount of money that we spend on boarders. So I'm hoping that everybody heard what you just said. Thank you for that. I also wanted to point out too that I know you said about the behavioral van, but I came across another program that actually involves police officers in a MIH program where they respond to mental health crises with paramedics and with community health workers. So, you know, in actually learning about the program, to try to become as expert as Miss Jacqueline Payne, I could never do that because every time I say something, she's already nodding her head in answering. So she knows it inside out. You know, and I also saw one for prenatal and postpartum care programs in some communities where they actually go in and they help pregnant, women, and assist them with all kinds of services, social services, housing, transportation. So I am really privileged to be doing this and sponsoring this legislation, but it couldn't have happened without meeting Ms. Greenwich Payne, you, Commissioner Encarnacion, and knowing that you actually had the program, moving forward, because sometimes people don't continue programs. They end abruptly when there's a change in administration. But when we see the good in something, we have to keep it going. And, the community needs to really recognize people like Ms. Greenwich Payne, because that's how change comes in communities, from people who just believe in their community and dedicate themselves to changing it. And under your leadership, I knew it would happen. I'm very happy that all the testifiers came out and supported it. And thank you, Mr. Chair,
thank you
for putting it on the agenda and we can get it done. Thank you, everyone.
Yes, and congratulations again to the bill sponsor. Just to follow up on the borders, I don't have a PhD, but in this scenario, the borders ain't somebody who got a piece of plywood and ponging it up. The borders, we're talking about the elderly persons who cannot provide for their self-care, and they normally end up in the hospital because they have no other means. And I think Wang Louis had about 3 borders. Ms. Commission, how many borders are there now at the Roy Lester Snyder Hospital?
Yes, Senator Tina Commission, CEO of Snyder Regional. We presently, and for a long time now, have had 9 boarders at our hospital, some of them consistently with us for extended periods up to over a year. several years, some of them, because
Yeah.
we don't have an appropriate discharge option for them, and there are no available beds in the territory, and there are no available contracted beds outside of the territory. So the hospital remains responsible for caring for them, even though we receive $0 for that care. No
Yes,
reimbursement.
Yes, the uncompensated care is very expensive, and that's why we have to act quickly on this bill number 35-0119, because anything that can reduce the cost of the boarders in the hospital is well worth it, because I think the boarders issue is about combining board hospitals, it's close to $80 million additional that the VI government has to come up with. So,
Senator, if I
yes.
may, please, we actually have a standing committee. We haven't met in reference to the borders. We meet about other things sometime on a Friday. So what we do is that we have actually both hospitals. We had human services as well as health. And Dr. Hans Caesar, who is our medical director, is also on the call for health to represent us. So we're working towards the reasons why we have borders, like Senator James spoke of, as to what we can do. And of course, human services and expansion of nursing home beds is actually critical, as well as behavioral health beds. So those are some of the things that we're speaking about. And so we'll continue that. Actually, CEO Comisión and I spoke about it just this week, that once we know we have a commission designee for human services, we'll be starting those meetings again in short time to continue these conversations.
Yes, thank you. Colleagues, I have some additional colleagues that have a burning question. So if any senator has a burning question, I'll allow it. Senator Gittins, you're recognized for your 2 burning questions.
Thank you, Mr. Chair. And the first one is, are there any statistics on how effective this program is in reducing emergency room visits and or even ambulance calls?
Jacqueline Greenwich Payne. We don't have any statistics in terms of the ER, but in terms of EMS, we do have some statistics of patients that were calling EMS and no longer call EMS. So I can always forward that back.
Yes, through the chair, if you can, the statistics in reducing these calls for service. And the last one would be, how does this program define its target population or patient demographics?
It's established to look at, one, the most vulnerable populations. We're looking at the elderly, those with chronic diseases, and it was a lot was stated, chronic pulmonary lung disease or COPD. We're looking at cardiac illnesses, hemodialysis or long-term diabetes and leading to wound care, as well as foot ulcers as well, and that's more venous ulcers that we see due to diabetes. So those kind of issues that we're looking at.
Hence the good communication and collaboration that will be needed with both hospitals. Thank you all so much for your testimony today and your responses. I'm truly looking forward for this measure to pass. We'll identify where the funding is coming from. I see that the bill doesn't have it specifically in there where the monies will be coming from, but we know that it is necessary, so I'm looking forward for this measure to pass. Thank you. And Commissioner, again, I'm counting on you to get that fully executed NOPA for Ms. Jacqueline Greenwich. Thank you so much.
Thank you, Vice Chair Gittins. Senator Caput, you're recognized for your burning question.
Thank you, Mr. Chair. Commissioner Encarnacion, in the proposed budget under transportation, I think you have 250,000. You're not using a van, so what is that 250,000 for transportation being used for?
That would be expansion of services. So yes, we can have the van. Actually, when I spoke with the director, she indicated that she actually has used other ones of our vans to be able to go out to see patients. So that will be incorporated in as well.
Okay. After you get your monies and you're up and running, do you plan to do like a education outreach campaign to let individuals on the island know about this service?
I think that, and our communication director is actually in the hall right now with us. That is something that just speaking to the individuals not right here who's actually testifying, not everyone was aware of MIH, and so I think that it actually warrants us going out a little bit more in the community, especially after the bill is passed and we have the funding. And I think that even in St. Thomas, what can we do, what must we do to ensure that we're going into homes a little bit more? I think education is always getting the word out there. So yes.
Okay, great. Thank you. Thank you for coming before us and talking about this good bill that I'm sure most of my colleagues would be buying into and supporting this legislation. Thank you, Mr. Chair.
Yes, thank you, Senator Caput and Vitima Director Jasin. You see, I know we have that little thing going back and forth about the meteorologists, but you see, today is a perfect day where you could use a meteorologist because, you know, you're so busy and all the other things that you have to do. And now, in addition, you know, right now, some of the airlines are not flying. They got, you know, continuing problems. We got, you know, high waves from the storm and potential, you know, flooding, flash flood and all of that issues coming along. So, you know, I'm still open if you think that Vitima can utilize a meteorologist to help us. You know, farmers now know that they got water, and there's a whole slew of areas. You know, you just let me know, and I'll be happy to sponsor and discuss that with my colleagues. Any opinions?
Senator, Director Johnson, thank you so much for your dialogue with this. I've been up since 3 o'clock in the morning talking to the meteorologists in Puerto Rico, and they're 24/7, 7 days a week, so they're outstanding, and I get updates also, but we'll continue to look at the options in the territory.
Okay, yes. So that way you could be at 3 o'clock in the morning talking to the governor and the commissioner of health and all of those other very important people in the team. Commissioner Encarnacion, before I let you Before I go to Senator Carrion, right? There's one thing I have to discuss with you because in Block 2 this afternoon we're going to have another dialysis option, and I have a bill to sponsor the kidney dialysis registry, and so. It's about $260,000. I have all the details. I just want to make sure that the numbers are correct.
That would be the numbers for any registry. My ask is that we have a dialysis log throughout the territory, which we already do, but the registry that is really critical is a diabetes registry, and that is because we focus more on prevention when we speak to diabetes. The diabetes registry can also incorporate the number of diabetics who are on dialysis. So it can actually work for both. So the dialysis registry is critical, and it can incorporate the diabetes registry is critical, and then incorporate the data that we need to identify for dialysis as well.
Yes, and you know, I want to keep reminding the public, right? The legislature, the 35th legislature, appropriated $700,000 a few months ago. It was due to expire or be expended in September. And right now, I'm urging property and procurement, the territorial board, and all the other players to sit down and get this done. Because, you know, right now we have 219 kidney dialysis patients. There's 125 on St. Thomas. Snyder Regional Medical Center has 75. There's 3 from St. John, 1 from Water Island. But the Caribbean Kidney Center has 51 patients on St. Thomas. On St. Croix, there's 93 kidney dialysis patients. Juan Louis has 40. But Caribbean Kidney Center has 53. Caribbean Kidney Center has more kidney dialysis patients on St. Croix than the hospital. So, folks, we have to avoid a kidney dialysis emergency. Let's get this agreement done. Senator Samuel Carrion, you're recognized for your burning question.
Great, thank you. Thank you, Mr. Chair. Commissioner, we want you to be successful, and I think this is a great program and much needed. But I do have a question in my mind. Are you foreseeing, or what could be some of the challenges that might affect the efficiency or this program to be fully implemented and be successful? What are some of the things that you might foresee that, if they're not in place, could really affect, maybe for you and the director?
To look more in a positive light, I would say that one passage of the bill codifies what the direction in which we need to go. Certification of the program also assists with that from a national level, as well as the obligation of the funds shifted to the general fund, so on an annual basis, we know for sure the staffing is actually going to be secure. So I don't want to look at barriers. I could say that those are what we need to do. And of course, leadership is critical as well. So identify key leadership to secure that. So we know that the director speaks about her retirement, but of course, training and education to someone to take over that position when she retires in about maybe 50 years, I'm just teasing. But those kind of things is really what we need to ensure.
Okay. Yeah, I just wanted to have an idea, because we want you to be successful, so not really looking at it as a negative barrier, but to be able to foresee beforehand, and that way gives us an idea to ensure these things must be in place in order for the success of the program. So thank you for sharing. Thank you, Mr. Chair.
Thank you very much. Senator Maurice James, you had any burning questions?
No, at this time, no, Mr. Chair. I just want to point out, though, I don't have a burning question, but I do want to point out that this begins with the Department of Health, but it can actually go throughout the community to other agencies, departments, even private entities, because there are, in other jurisdictions, private entities, nonprofit, community faith-based organizations, community organizations that also have MIH programs. But this one, of course, is the beginning.
Yes.
Thank you.
Yes. And thank you very
Senator?
much, Senator. Yes.
You spoke about dialysis, and I think it's important to note, for the community to know, that Governor Bryan actually pulled a meeting together. So we all sat in the room and came up with a plan on how we can actually avert any kind of emergency. I'm also speaking with the administrator for HHS, Administrator Gonzalez, who linked me with someone in Puerto Rico to see what we can do to avoid any catastrophe for a dialysis population within a territory.
Oh, excellent. That's music to my ears. Thank you very much. At this time, we'll ask all of the testifiers to give a 30-second closing statement. We'll start with Commissioner of Health, Encarnacion, and then we'll go to Darrell Dashan, and then we'll go to Ms. Sproul-Webster, and then we'll go to Dr. Tess on St. Thomas. Commissioner, you may proceed.
First of all, I'd like to say thank you. Thank you to you, Senator. Thank you to Senator James for putting the bill on the table. I like to use the word care coordination and case management, because a lot of us have been speaking about care coordination and case management, going back to the basic, looking at community health workers, looking at taking our mobile integrated health staff members and creating community health workers, linking them to more of a IT standpoint so that they can collect the data. There's so much that we can do, and so much expansion. I am a big believer that we are a territory and we're not an island, so incorporating the District of St. Thomas St. John is critical, so that's definitely something that we're going to charge ourselves to ensure that we complete. And so I'm just saying that I'm pleased to be able to be part of this, because it's something that is near and dear to my heart. And I just want to thank you and recognize the director, Jackie Greenwich Payne, for being adamant for being, how would you say, I'm going to just use the word adamant at this point in time, and thank her for her passion throughout these several years.
Thank you, Commissioner Encarnacion. Darrell, Fatima.
Thank you, Chairman. I didn't talk about this during my first testimony, but I want to acknowledge a tremendous loss also for the community of a true champion in the U.S. Virgin Islands, former Senator Alicia Chucky Hansen. We've been neighbors for the past 16 years. It's amazing. She's known me both in uniform and as a director for Vitima, and she worked me very hard in the last campaign for Governor Bryan and Lieutenant Governor Roach. My prayers and condolences go out to the family, of course, and members of the community who are grieving this loss. As far as to the bill, 350119, thank you again for the opportunity to present the background of 911, the system itself, talk about our tremendous dispatchers who provide this important service 7 days a week, 24 hours a day. And of course, Vitima supports this bill, and thank you, Senator Maurice James, for sponsoring this.
Thank you, Darrell Joshin, and Ms. Sproul-Webster. I definitely want to see that you get those, those syringe exchanges and stuff out as much as possible. So I'll recognize you for your closing statements.
Thank you, Senator Fonseca. I also would like to offer my thanks for the opportunity to testify today on Bill number 35-0119. I offer my congratulations to the Department of Health for the work that they have been doing in providing this service to our community. I would like to push for training particularly of our young people, somewhat like we do with Junior ROTC or Civil Air Patrol. If we could create a program like that so that we could start to get our young people involved and be groomed to provide some of these services. I still have a major concern about the amount of money that we're paying for for these services and to off-island organizations, and the money is going off-island. I too neglected to offer my condolences when I opened earlier, and I do want to offer condolences to the family of Senator Alicia Chucky Hansen, on behalf of Frederick State Health Care, my family and myself. I hope that the family would be comforted during this difficult period. And I thank you for the opportunity again.
Thank you, Director Sproul-Webster. And also, Dr. Tess, I know we didn't mention it today, but one of the emergencies that the Committee on Health, Hospital, and Human Services has been busy looking into has been making sure that your facility, East End Medical Center Corporation, does not close. And we're happy to hear that you've been successful in keeping that organization open, and because I know you serve thousands of patients. I just wanted in your closing testimony, if you can also give us an update on your financial status, if it's improving or if there's any special intervention that needs to come to the Committee on Health, Hospitals, and Human Services attention. I don't want any surprises. Go ahead, Dr. Tess.
Good afternoon. My mic. Hello? Oh, good afternoon. Dr. Tess Richards, Interim Executive Director at St. Thomas East End Medical Center Corporation. So first, I will start with your question regarding our financial status. We continue to improve. A lot of that improvement is coming because we are bringing on more revenue generators in our center. We have revamped our revenue cycle in its entirety. We are training our staff, supporting our staff. So that's a big part of us being able to generate more revenue, because now not only do we have more revenue generators, but our staff has a better understanding of their role in the revenue cycle. So that's been tremendously helpful for all of us. Number two, you asked for a wrap up with respect to this bill. I'm completely excited about this bill. Anytime I hear collaborating, reaching our vulnerable population, increasing access to care, bridging gaps. All of those things are at the heart of FQHCs. So to hear all of our healthcare leaders here talking about the importance of doing this, about their willingness to collaborate, this is extremely exciting to me. So I am absolutely in full support of this bill, and anything that East End Medical Center can do to participate in this, we're happy to do. Thank you.
Thank you, Dr. Tess. Tina Commission.
Thank you very much, Honorable Senator Ray Fonseca, Chair of this committee, and thank you to the bill's sponsor, Honorable Maurice James, for introducing this very important legislation. Thank you for allowing me to express the support of Schneider Regional towards this legislation. I definitely want to thank the entire team at Schneider Regional for all the great work they do in taking care of our patients, and I want to commend the Department of Health, Fire EMS, and the FQHCs for the important work that they do to provide care to people in our community. We think it's excellent that this program can offer support and in-home care for our most vulnerable citizens to help to keep them well and out of the hospital's emergency department, and to offer support to them when they're discharged, which allows us to discharge them and helps us to avoid readmission. So we stand in support of this legislation, and thank you for the opportunity to testify, and thanks to the great team at Schneider Regional.
Thank you, Tina. I can't see the scene. Thomas, clearly. Okay, yes. Leslie Evelyn, Fire, you may proceed.
Hi, Lyle Levin, Assistant Director of EMS. So Fire and EMS and Health Department, we are joined at the hip. So we continue to collaborate on a weekly basis. So I'm here to support any initiative that the Health Department has, because they assist us in many areas. I want to give kudos to them for providing the outreach van for us at the landfill fire for the past couple of weeks, and also providing the availability of behavioral support for fire personnel. So I'm supportive of this measure, and anything the health department needs, they know they can always rely on us to support it. Also want to give kudos to the brave men and women who have been battling the landfill fire for the past couple of weeks. Also individuals from St. Croix who came in to assist us. So keep them in your prayers. And as we commence Fire Prevention Week this week coming, continue to pray for the brave young women of VI Fire and EMS. Thank you for the time to offer testimony and support for this measure.
Yes, thank you, Director Evelyn, and it's so nice to know that you could confirm to the community that no fire service member was seriously injured in that Bovoni landfill fire. And finally, we will have Miss Jacqueline Greenwich, I'm sorry.
Greenwich.
You're recognized for your closing statements.
Again, a blessed good afternoon to everyone. I just want to say thank you, Senator Ray Fonseca, for bringing the bill to the floor. I want to extend my heartfelt thank you to Senator Maurice James. I also want to thank the men and women, which was just a handful of us from 2017, and when Pafford went back, it was 4 of us from the Department of Health, besides when the nurses would come, because the patient that had wound care, we had to see them on the weekends, Saturdays and Sundays, because the wounds were so bad we had to do them every day. So I want to salute those men and women who stand by my side, because a great leader has great support, and I do have an excellent staff, and I can't be up here to say that I did this good job all alone. So for my staff in the office, the regulatory office, our deputy commissioner that's sitting over there, Harriet Charles, I want to thank you all for the support that you give to me, that I could continue to doing the people's work. Thank you.
Thank you, Miss Jacqueline Greenridge. You know, I'm so proud of this bill. I have to thank the bill sponsor. You see, this, as you know, the Committee of Health, Hospital, and Human Services, this is actually the first bill that has come before my committee. So this would be the first bill. I have to thank Senator James. As a matter of fact, this bill is so important that some of the senators are asking me to delay the vote to make sure that they're here present to vote in favor. So at this time, the Committee on Health, Hospitals, and Human Services will stand in recess for 20 minutes. Oh, yes, and the testifiers are released. Thank you very much for your presence. The Committee on Health, Hospitals, and Human Services is back in session. Colleagues, we received testimony on Bill number 35-0119. All of the testifiers, Dr. Tess Richards, Tina Commission, Ms. Jacqueline Greenridge, Daryl Jessin, Justa Tina Encarnacion, and Daryl George, Representative Fire. Everyone was in favor of the bill. And I think at this time we're ready for a vote. Do I hear a motion? Senator Novell Francis, you're recognized for your motion.
Thank you very much, Mr. Chair. I'm honored to offer bill number 35-0119. My motion is, Mr. Chair and colleagues, I move that bill number 35-0119, an act amending Title 19 Virgin Islands Code by adding a Chapter 7A directing the Department of Health to develop and approve the mobile integration healthcare programs be approved by the Committee of Health, Hospital, and Human Services and sent to the Rules and Judiciary Committee for further vetting. I so move.
A motion, bill number 35-0119, Act Amendment Title 19, VI Code by adding a Chapter 7A, directing the Department of Health to develop and approve mobile integrated healthcare programs, has been made by Senator James and seconded by Senator Capehart, made by Senator Novell Francis, seconded by Senator Capehart and Senator Carrion. Are there any objections? Hearing no objections, roll call.
Senator Marvin A. Blyden. Senator Blyden absent. Senator Diane T. Capehart. Senator Capehart, yes. Senator Samuel Carrion. Senator Carrion, yes. Senator Ray Fonseca.
Yes.
Senator Fonseca, yes. Senator Novell E. Francis Jr. Senator Francis Jr., yea. Senator Donna A. Fred Gregory. Senator Gregory absent. Senator Kenneth L. Gittins.
Yes.
Senator Gittins, yes. Senator Maurice C. James. Senator James, yes. Senator Milton E. Potter.
Yes.
Senator Potter, yes. Mr. Chairman, 7 yes, 2 absent.
Bill number 35-0119, an act amending Title 19 Virgin Islands Code by adding a Chapter 7A, directing the Department of Health to develop and approve mobile integrated healthcare programs, has been favorably acted upon by this Committee on Health, Hospitals, and Human Services, and will be forwarded to the Committee on Rules and Judiciary for further consideration. Mr. Chair, please mark Senator Blyden's vote as yes. Can you give a new tally of the vote?
Mr. Chairman, it's 8 yes and 1 absent.
Thank you, Mr. Clerk. Bill number 35-0119, an act amending Title 19 Virgin Islands Code by adding a Chapter 7A, directing the Department of Health to develop and approve mobile integrated healthcare programs, has been favorably acted upon by the Committee on Health, Hospitals, and Human Services, and will be forwarded to the Committee on Rules and Judiciary for further consideration. Mr. Clerk, can you read Block 2 into the agenda? recognize the mic of the clerk.
Good afternoon. Block 2. The committee will receive testimony from Dr. Walter Roloff, MD, of the Kidney Center relative to at-home dialysis program, acute kidney failure, chronic kidney disease, kidney stones, hypertension, and renal transplantation. Invited testifiers, Dr. Walter Roloff, MD, the Kidney Center. That concludes the reading of Block 2, Mr. Chairman.
Thank you, Madam Clerk. You know, Dr. Roloff, it's, you know, it gives me a great pleasure to be able to present you to the Committee on Health, Hospitals, and Human Services. I met you in my office, and you basically gave me an outline, and we sat down, and I was so delighted to what you have to offer as an alternative, because right now, you know, I gave you the amounts of kidney dialysis patients in the community. There's over 200 patients, and as a matter of fact, on St. Croix, there are more patients now receiving kidney dialysis outside of the hospital in a private facility than on St. Thomas. And your system, your proposal offers an alternative. So I'd like for you to begin and give your name and your title so we can do a mic check, and then you may proceed with your testimony.
Good afternoon. Good afternoon. Thank you, dear Senator Fonseca, and thank you, senators, for listening to my presentation this afternoon. My name is Dr. Walter Roloff. I was born in Germany and studied medicine and kidney disease in Germany originally, in Berlin, later also in London, in Britain.
Speak in the mic directly.
Later also in London, in Britain, and subsequently at Tulane University. I did work in quite a number of different states in my career. I did work in New Mexico predominantly, but in many other states. In Albuquerque, I used to work at a kidney transplant center as a kidney specialist. And at some point, I had a work stint here in the Virgin Islands in 2012 and saw the swirling batons of the girls and boys during the carnival, and was enchanted and kind of came to the Virgin Islands. And I came back, and then 2 years later, I was asked to take on the directorship for the dialysis program at the Schneider Hospital. After that, I also was director on a volunteer basis for the Crown Bay Dialysis Center until its unfortunate closure in 2017. I have since moved on and I'm now in private practice. I'm not aligned with any particular facility as an employee, although I work with most facilities here in the Virgin Islands as part of my professional work. Now, I wanted to also talk about what my motivation is for wanting to give this talk. When I first was asked to join Schneider Hospital, the then Chief Medical Officer, Dr. Watson, specifically wished that I would also talk about the possibility of getting home dialysis options to the Virgin Islands. And this was looked like a very worthwhile proposal, because what the Virgin Islands in a way offers to a kidney disease is like offering a hammer to a carpenter and saying, do your work with the hammer, and that's it. There's only one tool, which is dialysis. When you are on different places, the mainland, anywhere, any town, USA, you will find people have not just hemodialysis as option, they have home dialysis options, and they also have much easier access to kidney transplantations. And what is increasingly important, we also have now many options to avoid dialysis or the need for dialysis as well, because we have new medications, we have new insights, much has changed. All of this is far away when you work in the Virgin Islands, where you only have hemodialysis. only in-center. No matter how old you are, this is the option we have. This is when you give a hammer to a carpenter and say, build what you need to build. But there's other things that require other tools, and you need to have those tools to provide the best possible care. So my experience after I was asked in 2014 to bring up home dialysis to the islands, of course, it was not just based on my shoulders. My predecessor had also been asked the same effort. He was not able to do it. I was involved in no less than 4 efforts, which included 3 corporations, the major players in kidney care, which is DaVita, Fresenius, also DCI. It included the hospital, it included the Crown Bay Dialysis Centers. It occurred in 2014, 16, 17, and 2018. I did my best at that time to see that we could get there, but as much as it was, I was involved in it, I was not able to help it along, and it did not come to fruition. I believe that this is the moment where the Virgin Islands has an opportunity to get there, and I will talk about that. What I would like to do as part of my talk is, and I need to actually give the talk a new title because the title is a little bit misleading. The title of the talk is really Kidney Disease Mitigation, Home Dialysis and Transplantation. Options for a way out of a deepening crisis for people with kidney disease in the US Virgin Islands. So what I want to do is first describe what the problem is and how much it affects us and how much it has worsened and is going to worsen, and then describe the options that are available elsewhere and that we might get onto the islands, and in the end have a suggestion. So the scope of the problem. Here in the Caribbean, we are particularly affected with chronic kidney disease. Chronic kidney disease is a growing problem throughout the developing world, or developed world, in particular in the United States. If you are of African heritage, 1 out of every 13 people will require, will develop end-stage kidney disease during their lifetime. This is an enormous burden. In the Caribbean, the number is even higher. The estimate is currently about 1 in 10. And this is an increase. This is actually the number of people that require that are increasing. There seems to be a particular Caribbean form of kidney disease that's recently been named Mesoamerican nephropathy. Its cause is not quite clear. Some people believe it is related to consuming certain substances, agricultural substances, agricultural work, but it is not fully established. In the following, I will speak about chronic kidney disease, which is the main portion as it affects us as a population. Chronic kidney disease, in its essence, means is something that affects about 6 people, 1 out of 6 people here in the Virgin Islands. For most people, this will be relatively slow in its development. What it means is they have a disease that makes them less able to eliminate waste products from their body with the urine. Most people will have milder or moderate forms of kidney disease that progress relatively slowly, but typically they do progress. And once they have reached stage 4 kidney disease, they will then over 2 years likely reach stage 5 CKD, which is the stage where people will at some point require dialysis in order to survive. The important things to know is this is a very silent disease until the very late stages, and even in the very late stages, often there are no symptoms to even suggest that there's anything wrong. And things may be very, the symptoms, the signs may be very mild, like feeling weak or so, or sleepy or drowsy, or have an appetite. And many of these things, since they develop slowly, are often attributed to getting older or other causes or neglected. Unfortunately, once kidneys have failed, repair is not possible, since the chronic progress of kidney disease causes scarring and destruction of the kidney architecture that is not reversible. Therefore, it is important to detect kidney disease as early as possible and intervene as soon as possible so that the progression of the disease can be slowed and that need for dialysis can be avoided altogether. There are certain risk factors that are particularly common and likely to result in need for dialysis later, which are diabetes, hypertension, getting old, African heritage, now also living in the Caribbean. COVID-19 was a recent factor. Consumption of toxic substances like NSAIDs, particular pain medications like Motrin, ibuprofen, Advil Aleve. And there's also certain herbs and plants that seem to be likely to cause kidney disease and kidney failure when consumed often. And this is important, particularly for the in regard to the Caribbean, the use of aloe vera taken by mouth or carambola, starfruit, can be toxic to the kidneys. So this may be a hard sell to the St. Croix, which had a carambola resort. And when I go to the farmer's market on St. Croix, I usually see at least 5 or 10 different carambola products. But it is important to understand that carambola can cause kidney stones, it can cause destruction of the kidneys, and it even can cause death, particularly in people who have already advanced kidney disease. However, when I talk to people, I find that aloe vera is much more frequently consumed, and this may be even more important than the intake or consumption of carambola. Now, what are the other issues? So as we already heard, there's 219 Virgin Islanders that are currently on island requiring dialysis service on both St. Croix and St. Thomas. There's also another 20 to 40 patients that are off island. They are not able to return to the Virgin Islands because of lack of suitable outpatient dialysis chairs. Some have started on peritoneal dialysis, home dialysis, but have not been able to transfer because we just don't have that option here. Patients that live on St. John and Water Island have no dialysis options on the islands and have to commute 3 times weekly to receive 4 hours of dialysis on St. Thomas during the most productive time of the day. Imagine that. So there is a time to commute, 4 hours on dialysis, and this happens 3 times a week on Mondays, Wednesdays, Fridays, Tuesdays, Thursdays, Saturdays, every week of the year, every month of the year, every year until the end of your life. The other issue is where we have problems, it's much more difficult to get to a kidney transplant. Younger people in particular need this option because they have most to gain in terms of lifetime and quality of life, ability to maintain what they want to do in life with a kidney transplant. Kidney transplant will offer more than twice the remaining lifetime compared to being on dialysis. So it's very important. People with a kidney transplant are also more likely to remain employed and active in their community, enjoy their life, and experience less treatment complications overall. Lastly, what I need to mention under the scope of the problem is the relentless growth of the end-stage kidney disease population. In June, at this very meeting, numbers were presented about how many people were on dialysis at the time, and I believe the number for the Virgin Islands was 50 people on dialysis in the 1990s. Now we stand at 219 in about 30 years. And this is pretty consistent with the growth that the United States has seen. And this is a growth curve. Unfortunately, I don't have it to show it on your monitor, but it is a curve that goes straight up. It does not slow to go down. In fact, There is actually a bend at the end, but this is only because we lost quite a few people to COVID, and that's why there's not as many people at the end of 2020 when this curve ended. So what I'm referring to is the Registry of Kidney Disease Patients for the United States. It's called USRDS database from 2000 to 2020. The end-stage kidney disease population in the United States has grown from 400,000 people in 2000 to now 808,000 people in 2020 and continues to grow. The number of people that newly come into this population is about 100,000 every year. In fact, this number is also growing. Used to be 95,000 in 2000 who entered that population, and now by 2020 that number was about 130,000.
Excuse me, Dr. Roloff.
Yes.
I just wanted to remind everyone that at 2:20 today there's going to be that emergency alert beep that's going to sound, and so I just want to remind everyone to turn off your cell phones. Just bring the mic a little bit closer to your mouth. You may proceed, Dr. Roloff.
So as you can,
if you could bring the mic a little bit closer to your mouth.
So again, the numbers for the kidney disease population has doubled in 20 years from 400,000 to 808,000, almost a million. So we might be close to 1 million patients now or soon. 80% of the cost for the care is covered by Medicare. The patients total of this, the total amount of patients with end-stage kidney disease is only 0.24% of the US population, but the cost for these patients out of the Medicare pie reaches 7%. This shows how disproportionately large the amount of money is that needs to be paid and expended for people that have end-stage kidney disease. Because of that, there has been increasing pressure to minimize the costs, and this has played out to only remaining 2 dialysis chains as major providers, which is DaVita and Fresenius. And these 2 chains now provide care for over 75% of the dialysis population. In the Virgin Islands, we are not aligned with any dialysis corporations. We are trying to do things our own, and I think this is why we have been failing and have been failing more and more, and why we are not able to really keep up with what's needed. We did, in fact, have home dialysis options and kidney transplantation in the Virgin Islands in the 1980s under Dr. Schneider. He introduced these options, and he was quite the visionary for what was needed for people with kidney disease at the time, but even he, in his own lifetime, could not maintain these treatments. On St. Thomas, the Crown Bay Dialysis Center opened in 2014, closed in 2017 because it was unable to meet costs. As you all are painfully aware, in June, the Senate took the decision to pay $72,000 every 2 weeks to bail out for a private dialysis provider, CKC, under Dr. Gardner, going forward. And also the government-run hospitals also generate negative balances that require intervention from the legislature or governor at times to support the extra costs. What this means is more and more of the resources in healthcare need to be diverted to dialysis and end-stage kidney disease care here in the islands, costs that may come out of cancer care or mental health care, where they're also needed. And this competition is not a healthy competition for the Virgin Islands. Another issue has recently been added. Medicaid unwinding has also added further costs because under COVID-19, Medicaid insurance was automatically renewed. Now has to be renewed based on individual criteria of the patients, and a number of patients currently on a number of patients have now lost their Medicaid insurance and may become burden of emergency dialysis services at the local hospital rooms unless this can be covered in some form. So what is the situation out of there? If we just keep doing nothing, we can really not expect that anything will improve. As I already mentioned, the number of patients are growing, and the reimbursement costs and ability to keep up with the falling margin of profit, if one can even call it that, is worsening. So we will not be able to survive this without continued bailouts from the government, Virgin Islands, to both public and private providers. So what are the options out of the situation? So options are, and I'm going to talk about that, is number one is to bring in new treatment choices, which is a mitigation program for kidney disease or also home dialysis. Number two, option to decrease the number of patients that will ever require dialysis services, which would be through an outreach program that mitigates kidney disease. Number three is to improve the survival of patients with end-stage kidney disease, which could be through transplantation or home dialysis. Number four, to improve quality and life of patients, again, through transplantation and home dialysis. Number five, an option to improve quality and stability of the services. That can be achieved through better staff retention, backup staff availability, ongoing staff training, financial stability of services, pre-established emergency evacuation routes for kidney disease patients when the next hurricane hits. And number six, options to achieve financially self-sustainable kidney care services that do not require ongoing USVI government interventions and subsidies. Number one option, to improve the treatment choices. I've in the handout that was sent to the senators, I compare the current United States Virgin Islands situation to the average U.S. Virgin Islands, average U.S. situation, as described by the United States Renal Data Service in 2022, and also with a possible mitigation program, so that one can see what the potentials are that we can gain if we engage with the situation. By current United States Virgin Islands situation, we have about 219 people on dialysis on the island, let's say 250 total with the 20 to 40 patients still off island. If we had the situation average town USA, there would be 213 of those on dialysis, not 250 total. On home dialysis here in the Virgin Islands, we have 0. Average USA, we would have 27. Transplant before dialysis, before they actually need to start with dialysis here in the Virgin Islands, is 0. Average USA would be about 8. Let's say we go with a mitigation program, and I'm plugged in the results of a mitigation program called REACH, which is a REACH is a mitigation program that could be available to the Virgin Islands. So if one looks at that, it may be able to reduce the number of in-center dialysis patients to 109, people on peritoneal dialysis to 105, and transplant before need for any dialysis to 16. Now, these numbers are a little bit too hopeful, I admit, because this would basically require that all patients would have to go through that REACH program, and not everybody will get through that program. Many people, as I mentioned before, are only found suddenly to have very severe kidney disease and almost immediately need to start with dialysis. So this would not be possible for everybody. Now, number 2, outreach program to mitigate kidney disease, to delay or avoid dialysis. These programs have been shown to be financially self-supporting by multiple models, and have the promise to basically achieve falling numbers of people that will require kidney dialysis treatment or transplants, and rather than the continued rise that we currently experience. Such programs typically focus on controlling diabetes, hypertension, lifestyle modifications, weight control, smoking cessation, dietary program replacement or reduction, avoidance of toxic substances such as pain medications, non-steroidal pain medications like Motrin, ibuprofen, Advil, Aleve, certain herbs and plants, especially aloe vera and carambola, and many others. In addition, we have now multiple pharmaceutical strategies that have become quite successful in slowing down progression of kidney disease. I'm giving the example of real-time, real-world results of a program called REACH, which is a brainchild of DCI. And REACH, the benefits of people with kidney disease who participate in the REACH outreach program over national average achieved in care are people are about 4 times more likely to be on home dialysis than in-center dialysis when they go through this program. They are twice as likely to get a kidney transplant before need for dialysis. They are about 4 times as likely to have the right kind of dialysis access in place, which offers them a safer outcome and better outcome. And they are 81% likely not to require admission to a hospital, compared to only 54% for people who are not going through such a program. The next option is transplantation. As already mentioned, people transplanted at any age will more than double their remaining lifetime. If we are better connected to transplant agencies, these numbers could improve significantly. We have in particularly, I have personally seen quite a number of young people in their 20s die on hemodialysis in center. And this is particularly galling when you see how their future is taken away of them before they ever have had a proper life. And statistics that I have included in my handout, for instance, for a patient at age 20 who is on in-center dialysis, his remaining life expectancy is only 6 years. There's many factors that go into that. If he gets a kidney transplant, on the other hand, his remaining lifetime is 19 years. So 13 more years than he can achieve on average by getting a kidney transplant. At age 40, still 6 years typical expected lifetime with start of dialysis in center. The lifetime with a transplant goes down to 12.5 years, still more than twice that time. If you're 60 years old, expected survival time is 4 years on dialysis, average survival time. With a kidney transplant, it is 9 years, again, more than twice that time. If you're 80 years old, expected survival time is 2.5 years. With dialysis, expected survival with a kidney transplant at that age is 6 years. Now, one has to say kidney transplant, of course, as you get older, more and more obstacles get in the way that make it more difficult. So this is mostly of benefit for the younger population, but they need this access in order to live their life, and we do very poorly in that respect. Home dialysis. So this is what I wanted to particularly home in again. Home dialysis is a form of dialysis that is less resource dependent than in-center dialysis because people do it at home. So much of the overhead, the staffing is not as intense as it would be for people that require dialysis in center. People on home dialysis only meet once a month with the nurse and the doctor at some office and discuss the progress of dialysis and changes that are necessary. Of course, issues occur, and then the patient can call the nurse and ask for advice, or the doctor as well if needed. So how is this done? Home dialysis is done different from in-center dialysis. We are lucky that we have the abdomen and a belly space. And you don't know what the abdomen can all be used for. In a nephrological world, the abdomen contains the bowels and many other abdominal organs, which are covered by a lining that's called the peritoneum. And this lining is like a filter. It allows substances to flow both ways in certain ways. And the principle is as such. Clean fluid can be inserted into abdominal space through a catheter and left there for a number of hours. The waste products that are in the body can then travel through that filter, the membrane or the lining that is around the abdominal organs, and get into that fluid. The fluid can then be discarded and replaced with fresh fluid, and that process can be repeated multiple times, and in that way waste products are moved out of the body, and substances that need to get into the body are moved into the body through the very fluid as well that is inserted. Typically, and this can be done without any need for electricity or running water. In fact, I used to work on the Navajo reservation, and we had one lady out in the that was able to maintain her dialysis for over 20 years on peritoneal dialysis without having any electricity at her home or any running water. So it is possible to do these services without any electricity. If VAPA is running, then we can also do this with the help of a machine, which will do this overnight, and people do not have to do any of these exchanges during the day and have the day free to do the things they need to do. Home dialysis is less expensive than in-center dialysis because of the less of overhead, and it is also provides a better quality of life, even some better outcome in terms of survival than in-center dialysis. So therefore, and it will, if we had it available in the Virgin Islands, it would allow people on St. John, on Water Island, the younger people to have much easier ways to maintain their life. The improved, next point I wanted to make is improved quality and stability of services. And this is basically to get to a place where we don't have this instability of nursing staff that is not available at times, where we have people that are not well trained or need more training in order to get into particular dialysis services, where we, and particularly if we need to increase the number of services, we need more trained staff and the availability of backups if the staff moves away. We have quite some transition here in the islands, which makes establishment of complicated services quite difficult. And that's probably one of the reasons why we've never been able to get to home dialysis in the first place. So, in my view, this is actually the main reason. So I believe the only way to really get out of there is to align the Virgin Islands with one or multiple of the large kidney care organizations that are available in the United States in order to achieve these savings, both for material costs through bulk purchasing as well as cutting overhead through making many services cheaper through having them in-house, like IT, billing, staff training, shipping logistics, laboratory and pharmacy services, and also to have a larger workforce pool from which to draw when local staff shortages occur. Then how can we get to financially self-sustainable kidney care that does not require ongoing Virgin Island government intervention and subsidies? Only today, I received a letter that the private provider on the Virgin Islands again will require further bailouts from the Virgin Island government in order to continue its operations, or it may have to close its operations in 4 days from now. The letter was sent to the agency, the Network 3, that regulates these matters, and basically puts the Virgin Island government in a difficult position to continue these payments. I believe that it is essential that the Virgin Islands will engage with one or two large dialysis provider organizations, and as it has tried in the past. And so I'm getting to the option that I believe is going to be very beneficial for this in this matter, which is the most likely to get us there soon. The closest to get there is the a new dialysis center that's going to open at Sunny Isle, Virgin Islands. Unfortunately, it is not open yet. It still requires further funding, but I believe that it will pay for itself. And rather than to continue with bailouts that do not get us to any new situation other than continued in-center dialysis, this option will bring us transformative changes in the Virgin Islands that will make things cheaper and will also establish many of these other services over time that I talked about. The Virgin Islands is a charity. The Virgin Islands Healthcare Foundation is a charity that was established in 2018 as in response to the hurricanes Irma and Maria and their devastating effects on the islands. It was created inspired by dialysis patients themselves who are from St. Croix. Many of them I know because I've helped out at times and saw them personally. They had gone through an enormous odyssey after the hurricanes. First, they were driven out from the islands because their facilities were destroyed. They went to Puerto Rico. It wasn't clear where they would be going. Then they were scattered through the United States. It wasn't people didn't know where they were. Relatives couldn't find them. They ended up, some of them, in very lonely places, and many did not return. Once they returned to St. Croix in particular, the hospital had failed to rebuild a dialysis center, and the only option was 2 dialysis trailers that were opened and that only had temporary licensing. When that option ran out, the hospital still didn't have a permanent solution, and they were told to simply sign up with a private provider, which all 49 patients refused to do in an emergency meeting in September 21. And instead, they successfully petitioned the federal agency, CMS, to allow them to continue to use the trailers on an exceptional basis, and then inspired the creation of the Virgin Island Healthcare Foundation with aim to build their own dialysis facility and treatment facility for kidney disease according to their own wishes. And this facility has now received over $1 million in ARPA funds allocated by Governor Bryan. Some of the funds are still to be allocated from and apparently hung up at the office of the OMB, as was reported in June 7, for not quite clear reasons. The center is 95% built out and basically requires additional funds for equipment and also to start operations. I believe that since the Senate has given a considerable amount of money and is about to give a considerable amount of money again in the next few days, I'm sure, to the Caribbean Kidney Center, to strongly look at the option to similarly fund the Sunny Isles Dialysis Center to be able to open its operations. The reasons why this is so transformational, in my view, is because it will come along with DCI, and DCI is going to be, in my view, the key to getting the islands to a different place in healthcare in terms of kidney disease. DCI is a large dialysis provider, but it's not for profit like Fresenius or Davida. Was founded in '71 and was focused on excellent patient care. It has the best outcome of all the large chain dialysis care providers and invests a large amount of money of its resources to spearhead improvements in kidney care throughout its alignment with universities. It has over 300 dialysis centers and operates 120 hospital-based dialysis programs in over 30 states. DCI is the nation's largest nonprofit dialysis provider. It's headquartered in Nashville, Tennessee. It employs over 5,000 people that serve more than 14,000 people with kidney disease. The mission of DCI is we are a nonprofit service organization. The care of the patient is our reason for existence. Once DCI comes to the Virgin Islands, I believe many of the services which are routinely available to its patients on the mainland will also become available to us, which includes the outreach program that prevents need for kidney disease, treatments with dialysis in the first place, and slows down the progression of kidney disease, as described earlier. They have make it easier to get to a kidney transplant since they have their own kidney transplant procurement program. They likely will be able to offer a home dialysis program such as peritoneal dialysis, which can be operated for all islands from one base, which may be on St. Croix. And it is likely going to be financially self-sustainable through lower costs achieved by bulk purchasing, in-house billing, IT services, logistics, staff training, laboratory services, and access to a large staffing pool to fill shortages. And lastly, it will also provide us emergency access and transfer to more than 300 mainland dialysis centers when the next hurricane hits. This concludes my presentation, and I thank you all for your attention.
Yes, thank you, Dr. Walter Roloff, MD. Just some background information. So at one point in time, you used to be the director of the Roy Snyder Kidney. Give me that update again.
I was employed from 2014 to 2018. I resigned in 2018 because we could not get, I was interested to get DCI to the islands at that time, and that did not work out. And I was very disappointed with that we didn't go anywhere else.
Okay.
And I felt that I could be more productive and helpful in opening my own practice, which I did. And so I'm working on mainly on prevention of need for end-stage kidney disease services in the first place.
Okay, so you're a private local physician?
Correct, yes.
And what's your specialty?
It's kidney disease prevention, chronic kidney disease, kidney transplantation, acute kidney failure, kidney stones, hypertension.
So you're a nephrologist?
Correct.
Okay. Couple questions. We're going to go to around a 4 minutes questioning. So you said that Medicare, it's 80% covered by Medicare. And so this home dialysis procedure, if it's covered by Medicare, it must be sanctioned by CMS. It's fully vetted.
Absolutely. So the way how it would get to the island would be through being aligned mostly, most likely with a large dialysis organization. But even an independent center can open, theoretically, its own peritoneal dialysis option. But it would be very difficult to get there because there's a lot of logistics, a lot of red tape that needs to be done that large organizations will do much better, particularly movement of large amounts of fluids that need to be exchanged with home dialysis. That will be difficult to achieve in a financially sustainable manner. But this is a well-established method, and all the insurers would be happy to do it, support it, because it's actually cheaper for them, it costs less.
Okay, and before I go to Senator Blyden next, you made a comment that in 1990 there was about 50 persons in the Virgin Islands on kidney dialysis. I think in 1990 we had a larger population than we have today, and now we have 219 persons. That's what the Commissioner of Health gave me today. So we're 5 times the amount of people in a space of less than 30 years. Is that what you're telling us?
This is what it appears to be, yes. Mm-hmm.
Okay, thank you very much. Senator Blyden, you're recognized for your 4 minutes.
Thank you. Thank you, Mr. Chair, and good afternoon again to my colleagues, and good afternoon to the testifier, and thank you so much for that in-depth testimony. I learned some new stuff today. In respect to your testimony, though, there are several questions I have. But my first question is exactly what's the ask in terms of what we are trying to accomplish? What's the main goal in terms of your presentation?
My main goal is to see that you hopefully support new options. When people give you solutions, that you ask for 2 things. Number one, that they are self-sustaining financially, and also that they include new tools, which is home dialysis, in particular peritoneal dialysis, kidney transplantation, access to be improved compared to what it is now, and also a mitigation program that allows people to not even need any of these services by earlier intervention, more aggressive intervention.
Okay, very well. Thank you for that explanation. So basically you're saying you're trying to see how we can have more access in order to assist more individuals with this chronic disease, basically here in the territory, having more options for individuals.
More options, yes.
Okay, very well.
And and I should also add, I also ask that the Senate considers in its means to support the other dialysis center that is about to open, but it still needs some help to get over the final hurdle, also financially or in which other way necessary to open up, because I believe this will be what will make the change the quickest and the most likeliest so far.
Okay, and you spoke to aloes and how that affects many individuals, and here in the territory, aloes are very popular
exactly
item that we utilize, and that's the first time I'm hearing of this. Can you expand on that for a little bit, please, in respect to your research, because you did a lot of research basically, but aloes, speak to that, because many folks don't know that, especially many Rastafarians, they don't think so. So can you speak to that, please?
Sure, thank you. Thank you for the question. I did not know about that until I came to the Virgin Islands, but it is also not very common to ingest aloe elsewhere, but it's very common in the Caribbean for treatment of constipation in particular. People use it to cleanse out, they mix it with orange juice, very popular. And many people do this on a near daily basis, a weekly basis. You basically have to imagine anything that you take on a very regular basis, you better know that it's safe for your body. And effects that a one-time deal often doesn't really matter. It's like being drunk once in your lifetime hardly matters. If you're drunk every week, you know what the effects are. So then it accumulates. What aloe seems to do, it seems to inflame the kidneys in various portions, and before the inflammation dies down, the next allo comes down the tube, and the kidney has again to deal with it, and the inflammation never stops. And this chronic inflammation in the kidney then causes scarring in the kidney. The scarring destroys the architecture, and people end up on dialysis. Now, this is, if a scientist would listen to what I'm saying, it would probably say, well, not so fast. Of course, there's a lot of research that would need to be done to establish that with absolute certainty. And that research really needs to be done. And DCI, in fact, would be another partner for things like that, because they do support, through their money, also research at universities in this field, so that would be helpful. But it is described as one of the agents that cause kidney failure. I can, from anecdotal, from talking to my patients, I've seen that people have improved with their kidney function after stopping aloe vera. This doesn't prove that this is exactly that, but could be other things too. Many things affect the kidney. Things can go up and down, but certainly I would support that from my own practice, that I've seen that, because I always ask people, are you using aloe vera, yes or no? Are you using pain pills, yes or no? How often do you use them?
Okay, very well. Mr. Chair, can I wrap up? I have two quick questions.
Yes, and Dr. Roloff, please stick to a direct answer to the question.
Okay, you also mentioned that home dialysis is generally less expensive than in-center dialysis. Usually about what percentage? How much less inexpensive is home dialysis? And are there any issues in terms of safety?
Patients are trained for about 2 weeks before they start with home dialysis by a nurse. They go to a center and then are shown how to do it, and then observed to do it for themselves before they are released. The outcome in terms of the people who go through the training do better. They live slightly longer, and are about equal in terms of need for, actually less need for hospitalizations than people on in-center dialysis. So it is safe. Now, in terms of cost, that depends on the setup, but in developed countries like the United States, and if you're part of a larger organization like Fresenius, DaVita, DCI, cooperate with them, then it will be cheaper. It is slightly cheaper than how much, I can't really give you exact numbers, but it is certainly cheaper than in-center dialysis. Maybe, let's say, if you want a ballpark, maybe say 70%, 80% of what hemodialysis, in-center dialysis.
Okay, thank you for that. And in closing, in respect to your testimonies, you stated younger people are pursuing active lives and people living with dialysis, right? In respect to your research, what percentage would you see of that 250 you spoke of in the Virgin Islands are younger people? You said there's about 250 people in the Virgin Islands on dialysis. Of that 250, what percentage would you say are those younger people? And of the 20% that voice interest in this type of treatment, what was the reason for agreeing to that? Thank you so much, Mr. Chair, for the time.
Yes.
I would guess it's about 10% or so of people in their 20s and 30s that are on dialysis. And people mainly on the islands where there's no dialysis, like St. John, Water Island, they are particularly interested in home dialysis because of the commute that they have, and also the younger people. Of course, if you have to do dialysis yourself, you have to do it yourself. There's nobody else who comes in. There's no cavalry is coming when you don't do it. So you have to be physically willing and able to do that and not tire of it. And for young people, that's an option that they can more easily do.
To follow up on, and thank you very much, Senator Potter. How about dedicated persons? What is the total amount of persons that will be needed in a home dialysis situation? The patient is trained, and then you said they visit the doctor, the healthcare provider once a month. Who else is involved?
Thank you for the question. That's very important. Basically, you will have also dialysis nurses that are assigned for the home dialysis pool, and they, depending on how large the program is, they would also be can be quite sizable. And this is the reason why the costs are not that much cheaper than in-center dialysis, because you still have a lot of overhead in that respect. People who need to be available, people who need to do training, people who need to do certain testing. So it's at least 2 to 3 nurses that would be full-time assigned to home dialysis. I would think would be a starting point. So that they would share the calls, the 24/7 calls, to be available in the first line, do the training of patients, do the follow-up with patients, and then participate in the visits.
Okay, and then before I go to Senate President Francis, I just wanted to, just for the community to understand, you are a full-time nephrologist in the community since what year? How long have you been providing this service full-time in the community?
I've been providing services to the community full-time since 2014. And I never left the island, so I've been on St. Thomas since 2014, full-time.
Okay, thank you very much. Senator Novell Francis Jr., you're recognized for your 4 minutes.
Thank you very much, Mr. Chair, and good afternoon, and thank you for your testimony. I wanted to ask you, getting back to the issue of aloe vera and carambola, what is it about these two items that you believe present some challenges for kidney dialysis or renal failure?
Again, it's basically the frequent use, most likely, and both substances have an ability to inflame the kidney in various portions of them. And if people take these substances on a chronic basis, as you know, when you have an inflammation on your skin, it's red for a while. It's not, when you have angered your skin, it doesn't immediately heal. If you keep putting salt on the same wound again and again and again, at some point you're going to end up with a scar. It will not go back to the normal tissue. In the same way with the kidneys, when you keep doing the same thing that is toxic to it on a frequent basis, you will end up with a scar that destroys the kidney. And that's kind of what I would propose. Now, carambola also causes kidney stones. And if you look into, just Google carambola death, you will find quite a few carambola kidney disease and death. These 3 things together in one line. Google it, you'll find quite a lot of reports about death, particularly in Southeast
Okay,
Asia.
so the issue of aloe vera, because I kind of Googled it as well, I talk about the electrolytes and those type of issues, but it seems to hamper those individuals that already have renal failure or some type of kidney disease, then it worsens the situation. I don't know that, or I don't know if your research have determined that someone that do not have the issue of kidney disease or renal failure, how then will aloe vera impact that kidney?
Dr. Rolf, can you speak directly into the mic, please? Pull
Yes,
it up a little
yeah.
bit. Yeah.
I think that's an excellent point, because what it basically says is if you start off with any kind of kidney disease, you're already at a more vulnerable point. And that's because obviously your kidney has already reacted to something before. It has an ability to malfunction to some degree. And if you then throw in any kind of other toxins, and there can be many different things, then you can upset the situation more. And so that's basically many different things can play out and do harm to the kidneys over time. Now, like with many things in life, in organs, we are designed to take a number of injuries and survive them well, and end up with organs that are not perfect, but in order to live, we don't need to be perfect. Things need to be good enough. And so it's important to avoid frequent multiple injuries to the kidney, and aloe vera may be one of them.
Very
like
well.
other things.
I'll move away from that because obviously a lot of times based on your testimony as well as research, 75%, by the time you determine that in fact that you do have some type of kidney disease, you're already 75% into it because again, it's one of those situation that it's not glaring, but it's really one of those unknown illnesses that only impact you when it's severely impacted by 75%. What are some of the contributing factors? You spoke about that we're currently almost four times the amount of, we have seen at least 4 times the amount of kidney failures compared to the 1990s. What are some of the contributing factors?
The main factors that have been described as the driver of that is the growth of diabetes, obesity, in particular, also age, and now also other factors like COVID.
Hypertension.
COVID-19 also has added a number of people to the dialysis population as well.
Very well, thank you. Mr. Chair, if I could just wrap up with 2 more
Yes,
questions
you
real
may.
quickly. So you talk about the issue of home dialysis, and dialysis is a real problem throughout the Virgin Islands currently. And we were trying to really get a strong hold on this dialysis issue. But the home dialysis that you're reporting, how many patients are you currently seeing in your home dialysis program? Are you aware of?
How many patients do I have personally on dialysis here?
Yes, yeah.
I have 38 patients on dialysis.
Home dialysis?
No, here, no. In-center dialysis. I don't have any home dialysis. I would like to have home dialysis.
So you have 0 at this point?
Correct, yeah. It does not exist in the Virgin Islands.
It does not exist.
We need it.
Very well. Okay, so that put a little bit of a difference in it. So your advocacy here today is that we need to look at home dialysis as an option.
Correct, yeah.
Very well. Thank you. If time permits, I have a couple more questions I'd like to ask about that home dialysis program. Thank you very much, Mr. Chair, for the time.
Thank you, Senator Francis. Next, we'll recognize Senator Maurice James. Senator James, your 4 minutes.
Thank you, Mr. Chairman. I was actually going down the line of questioning about the home dialysis that my colleague just asked about. I wanted to find out a little more about the home dialysis now that I know it doesn't exist in a VA. When I read it, it said that it takes 30 minutes each time, and then you have 4 exchanges of fluid. Does that mean that 4 times 30 minutes?
That's correct, yes. It would be 2 hours per day, roughly.
But every day?
Every day, yes.
Home dialysis every day?
Yes.
Okay, how does that compare to going to a place? I'm not familiar with the
You
process.
mean time-wise?
Yeah, how does it compare home dialysis to in-center dialysis?
So in-center dialysis would be 4 hours, 3 times a week would be 12 hours. So the other one would be per week. And so this one would be 2 hours times 7, 14 hours per week.
Well, every day, two
Correct, yes.
hours, 7 days, as opposed to 3 hours or 4 hours, 3.
So 3 days, on 3 days you do 4 hours each, so which is 12 hours. Versus you need 2 hours to do your 4 exchanges every day on 7 days, which is a total of 14 hours per week.
Yeah.
Now, but if I may, if you have a dialysis machine, overnight machine, VAPA works. Yeah, that's the assumption. You do this overnight. You connect yourself overnight, and you disconnect in the morning, and then you don't have the daytime hours. You don't have the daytime exchanges. You basically have your day free. So that's the difference.
If you have a machine, you can do it overnight. That's what you're
Correct.
saying.
Mm-hmm.
But manually, I'm just concerned about how many people would actually follow through and be disciplined enough to do it 7 days a week. You said it? Did we ever have in-home dialysis before?
Yes, yes.
We did.
I did it actually in the Indian reservation in Arizona. I had
in the Virgin Islands.
Not in the Virgin, but it has existed here in the Virgin Islands in the 80s. I wasn't there, so I don't know.
Oh, you don't know. That's what
but
I wanted.
it was available here in the 80s under Dr. Schneider. Yeah.
That's what I wanted to find out, how effective it was and whether or not people were disciplined enough to actually do it 7 days a week, 2 hours a day, because with this type of disease, it seems, I mean, you must do it in order to clean the blood, right?
Correct. Yes.
1 minute.
Time? 1 minute. Okay. And then that's my biggest concern. Okay, my other question was, you say that somewhere I saw where you said, you said need for commuting thus only occurs once per month, and therefore also only one home dialysis base is needed in the U.S. Virgin Islands.
That's correct.
So that would be like a doctor's office where they would go. When you say home base, I didn't understand.
But the home base is where the basic dialysis nurses are located, where they have the records and where they keep all the relevant test results, and where they basically where they're home too. So they might do the training there, 2 weeks of training for a new patient at that base, but otherwise for the visits, the nurse might travel by airplane to any island and meet with the doctor there and the patient there once a month.
May I?
Yes.
Can I continue? I'm trying to get to the bottom of how it works. So there's one place where all these home dialysis patients would go once a month to make sure that, I guess it's like like a check-in, a checkup?
Yeah, let me give you some idea. Yeah, so basically, let's say people from St. John who want to do that, they would travel to East End Medical Center, and there would be a room set aside for once a month to meet with home dialysis patients the whole day. And then the nurse would be there, the doctor would be there, and go over the treatments and make adjustments.
But let me interrupt. But who oversees this entire operation then? It's not that they're going to different doctors. They're going to one established entity that oversees the entire home dialysis program. Am I correct?
The nurses would be for all kidney doctors that participate. And I would, for instance, be this doctor who goes to the East End Medical Corporation place and see patients there. Or they could maybe meet in my office, would be possible too. You know, but there would be there could be different doctors. Dr. Hunt, for instance, could see his patients. I could see my patients. Could be different dates, different times. Yeah. But it would be once a month. So the traveling needs for the nurse is not that much. So a nurse could be based on St. Croix, with the whole program being based in this unit rather than having it multiple units. Like an in-center dialysis center, you need the center really on the very place where you provide it.
Okay, I'm going to move on until I get another chance, I guess. But at this point, I probably need to do a little more research myself to see how it works, because I'm not really understanding how effective and efficient it would be right now. And that's just my trying to get an understanding of it. Thank you.
I'm happy to talk afterwards too, if you want to.
Yeah. Thank you very much, Senator Maurice C. James. Senator Marvin Blyden, you're recognized for point of information.
Yes, thank you, Mr. Chair. Let me ask you in respect to my colleague line of questioning when it comes to in-home dialysis and doing it every day. Do they have to be the same time period in terms of, do we have to be 2 o'clock every day, or you just have to be doing that day? That's my question. Thank you so much, Mr. Chair.
There is some variation. If you miss a day of doing dialysis, it's not immediately dangerous necessarily with home dialysis as long as you do it most days. You can miss a treatment. It's just you have to do a certain a number of treatments per week in order to do enough cleaning. It's like if you leave things left over, then they're left over. They need to be done at some point. So, but it's not you have to be on a certain schedule. Absolutely, not so. I mean, for the most part, it is correct. You need to follow a certain schedule if you do manual exchanges only. But again, you always have to compare that to if you have a machine, you don't have to necessarily do any exchanges manually during the day. During the day, you have the day for whatever you want to do, and you only connect yourself at night to a machine to do the exchanges through the night.
Thank you. Thank you very much, Senator Blyden. Senator Novell Francis, you're recognized for your point of information.
Thank you very much, Mr. Chair. I know that you're still talking about us developing this home dialysis program, but what would be some of the prerequisites? What are some of the criteria that be required for you to have an effective home dialysis treatment?
You have, I think at the center of it is a very dedicated and experienced nurse who does home dialysis, because she would be the one to do the training and who is the first in line to provide these services. You need stability. So the frequent transitioning through, going through multiple different people is going to be much more of a problem, because the person who is at home depends on that particular contact quite a bit. You want to know who you're talking to when you are a patient, and also the nurse needs to know who she's talking to when the patient calls and asks questions in order to understand how urgent is that. Or what do I have to run, or can it wait? How reliable is the patient? Can the patient do this and that? So it is a much more interpersonal relationship than for people who are on in-center dialysis. So that's the main basis. You also need a financial, you need a training backbone. You need a backup for if there's staffing shortages. So because there's not that many people who do home dialysis, there's not going to be as many nurses in it. So it's more difficult to maintain that as a stable program. Again, that's why I think you really, for this particular thing, you really need a large corporation as a partner to be able to achieve that. So to have that kind of backup and support that's needed. Also logistics for the amounts of fluids, because you have to imagine the amount of fluids you have to manage in a month is a pallet full of fluid, and you have to store it somewhere, and it has to somehow be shipped and brought to your home. So this is not so easily done.
Thank you very much, Senator Francis. Two quick questions. Have you approached the Commissioner of Health with this proposal? Have you ever presented this to the Commissioner of Health?
I have not.
Okay,
be happy to present it to anybody who will listen.
Yeah, based on the testimony here, I think it would be most appropriate if the Commissioner of Health had a chance to review this, and then then it comes back to the Committee on Health, Hospitals, and Human Services. Not that I'm saying it's not valuable. I can see the benefits. Just your statistics, where we had in the 90s, we had 50 diabetes patients. Now we're over 200. That alone tells us that we have a diabetes problem. But I wanted to follow up on one statement you said. You made a comment that the funding that the legislature had appropriated may have run out, and in 4 days there may be a shutdown. Can you expand on that statement?
There was a letter, I was informed by Chris Brown. Chris Brown is...
a letter from who?
Chris, from Dr. Gardner, that was addressed to you, as well as also to Mrs. Commission from Schneider Hospital, that CKC may need to close down this Saturday. cease operations unless certain conditions are met. So, I mean, this is the letter that was sent out that I received as a copy from Chris Brown, the chair of the the Renal Network 3, which...
Okay, well, thanks for letting me know. I'll look into that today. Senator Milton Potter, you're recognized for your 4 minutes. Media, please recognize the mic of Senator Potter.
Thank you very much, Mr. Chair, for that. Dr. Roloff, thank you very much for your very informative presentation. I learned a lot, and it's clear that we need to channel our efforts and our resources on the prevention side for sure, while still identifying some more viable treatment options for persons who are suffering from end-stage kidney disease. And the numbers, as you indicated, are on the rise. Sadly to say, we all know someone who was affected by this very serious illness. I think that the option of home dialysis is definitely a viable one. It may not be for everyone, but I think it provides an excellent option for some. One thing that just jumped out to me, though, is there going to be a requirement for stable, steady electricity? Is if we have, power surges, that happens periodically, how does that impact the ability to, be adequately dialyzed?
Yeah, thank you for that question. And so the importance here is that there are two home dialysis options. One requires absolutely no electricity, which is the manual exchanges that people do during the daytime that take 30 minutes each time to do, of fluids that they connect and disconnect during the day, doesn't need electricity, versus having a machine that will do the exchanges for them during the nighttime. So when electricity is running, and thanks God, usually at night, WAPA is working better, the machines can run and then do the dialysis, and then during the day, no further electricity or exchanges are needed if this machine has run during the day. But there's always a fallback option, which is a nice thing. People will always be trained in both methods. So when WAPA is out, they just go back to square one and do the exchanges manually. And as I mentioned,
right?
Yeah, go ahead. Yeah. So
no, it's all right. I appreciate that. I mean, are there any studies, just from your experience, that compares the, both treatment options, both the home dialysis model as well as just the traditional dialysis, going to the kidney dialysis center? Are there any studies to compare how patients do, general patient outcomes, home dialysis versus traditional dialysis?
Yes, absolutely. I should mention there is a United States Renal Data System, USRDS, that is actually a dialysis registry. We heard about that earlier in the first portion of today's hearing, that there's an interest in creating such a registry. There is a large national registry where one could maybe get the regional data that does compare outcome very closely, and so the outcome is very well known. Again, the outcome, peritoneal dialysis patients tend to do a little bit better in terms of living longer, having less need for admissions, do better in terms of their life, quality of life, ability to be working, compared to hemodialysis. And it is financially also slightly less costly.
Okay, thank you for that.
Time.
Just one question, also for my edification. how is kidney stones? How is that connected or related to kidney disease in general? Is there a connection between end-stage kidney disease and occurrences of kidney stones?
In general, there is not a lot of connections. It is possible with kidney stone disease, you are slightly more likely to develop end-stage kidney disease, but that is not the main complication.
Okay, thank you for that, Madam, Mr. Chair. I don't know if my time was called.
Yes, but you may wrap up.
Okay, just one last, final question. It's about just the whole initial setup and training, and I think you may have alluded to it that at some point, or the nurses, I guess, providing training for the patients who opt for the home dialysis, and I wanted to get a sense of how that would go. I don't know if that is what you mentioned, that all-day affair where everyone would come together with their dialysis nurse and the physician to receive training and support. Is that how that would go?
Sorry, could you please repeat the question? I didn't quite get the gist of it.
Well, it just was if someone opted to go the route of home dialysis, what sort of training regimen would they be required to undergo as a patient who is now doing the home dialysis in the privacy of his home, away from, I guess, the security of the medical professionals at the dialysis site? So I just wanted to get a sense for what sort of training was required before one was entrusted with doing the home dialysis regimen on their own.
Obviously, the physicians are trained at their training institutions before they are certified as nephrologists, kidney specialists. The nurses would have to be trained within a PD program, so that's why they need to be experienced and work there for a while. The patients themselves basically undergo a 2-week training, typically with the nurse at the facility base. So let's say St. Croix, Virgin Islands Healthcare Foundation, and then there would be a 2-week program where the patient stays on the island, basically, first observes how it's done, then does it under observation by the nurse and gets re-instructed. In my handout, I actually put in a link to show you a home training session that shows you all the steps needed to do your exchanges. So this would actually give you a very good idea of what's required. And you really do not need to be trained in medicine to do your own dialysis. You just need to follow steps very closely. And the number of steps is not, it can be managed by people who, they do not have to be academically trained or medically trained. As long as they can follow instructions well and will follow instructions, they are candidates for doing this procedure themselves.
Thank you very much for that, Dr. Roloff. I will definitely click on to the link and see it in person. I think it's a viable option that we ought to look into a little closer. Thank you very much, Mr. Chair, for your leniency.
Yes, thank you, Senator Potter. And I think that's the general consensus of the committee that, this is very interesting and we can see where we can save lives and at the same time reduce costs. But we'd recommend that you pursue the Commissioner of Health and then have it be channeled to her, and then she would make recommendations. Colleagues, I think we've exhausted our line of questioning on this subject. And basically today, the committee approved Bill number 35-0119, an act amending Title 19 Virgin Islands Code by adding a Chapter 7A, directing the Department of Health to develop and approve the mobile integrated healthcare programs. We're very excited for this, and hopefully the full session can act on this bill and it be favorably approved by the Rules Committee. At this time, Dr. Walter Roloff, I'll give you 30 seconds to give a closing statement.
Thank you again for your willingness to listen to my presentation. It has been my pleasure to do this, and I very much hope that the Virgin Islands can improve its healthcare operations, particularly for people with kidney disease, in this very important fashion, because I think we are far behind where we could be, and it costs us far too much. And it is very important that we make the necessary changes as soon as possible to get out of the morass that we are currently in. Thank you so much.
And thank you very much for coming. And the Committee on Health, Hospitals, and Human Services is adjourned.